the first thing I want us to talk about is just how other healthcare systems work. And then we're going to go to the list of problems in the American system, which there's like a ridiculous amount of facts which demonstrate them. Just for anybody who's a defender of the current system, you're absolutely wrong. And then we're going to go on the many ways that me and Econo Boy agree about how we solve it. So the first thing is, let's talk about...
Post the map in the show chat.
In the show chat?
Yeah.
Okay. Here, let me. So first, there's basically 3 different types of healthcare systems we see in the world. And we'll go model by model. First, there's the beverage model. This is like the National Health Service, publicly owned, most like socialized medicine model, like actually socialized medicine. So the providers are owned by the government and the insurance is owned by the government. And basically the government taxes everybody to finance the system. You don't really pay very much when you go to the doctor. Maybe you pay a slight copay, a pretty low deductible for certain types of treatments. And the government's just it's the place you go. If you're kind of rich, you might go to some supplemental private providers, but the vast majority of care is funded by taxes and planned by the government. Now, there's 2 different kinds of beverage models. There's like the UK style where there's the national government is the one that's really responsible for doing the healthcare planning. And then in countries like Scandinavia, Norway, Sweden, Finland, there's a decentralized model. So the government sends out money to local governments or regional governments, and they do the healthcare planning. So the beverage model is used in the UK, it's used in Scandinavia, it's used in Spain, Portugal, Italy, and sort of Greece, and sort of New Zealand, and maybe Australia, and also North Korea and Cuba. So
there's a lot of differences. Like if you're, again, I was talking to Micah before this when he was making this map. Like if you're going for that strict binary classification, there's obviously you can quibble with this map and say, well, actually, I mean this and that. It's like we're just kind of roughly categorizing these things. Obviously, there's going to be some gray area between these models that, or perhaps some new models that you haven't thought of. But that's the beverage model. And then next up, you've got the Bismarck model. Micah, what's the Bismarck model?
Can we expand the map to make it larger?
Can we expand the map to make it larger? I honestly don't think that we can.
There it is. Okay.
Cool. Oh, okay. Oh yeah, no. On the big screen, yeah, people can see it.
Okay, I just hope they can read the words. Like red is beverage, blue is Bismarck, green is national health insurance model. Okay, here's the next model. The national health insurance model. Okay, so in this model, the providers are still private, largely nonprofits, also for-profit companies, maybe a few public institutions, okay, in the mix. But the insurance is largely provided by the government, and it is financed by taxes. This is how it works in Canada. This is how it works in Taiwan and South Korea. There's plenty of other countries which are not usually considered single-payer systems, but really are. One good example is France. In France, it's not considered single-payer because the government splits the insurance pools between like different regions. But everything is managed, all the insurance is managed by the government. So we still consider it single payer. This is also something that many Americans will be familiar with when it comes to traditional Medicare and proposals to expand traditional Medicare and enroll everyone in it. So what Bernie Sanders calls for. The last model that's used around the world is the most market-based model. It's called the Bismarck model, also called managed competition. So in this system, both the providers are private and the insurance companies are private or nonprofits. The insurance companies compete in a very heavily regulated individual insurance market. So individuals go to purchase their own insurance on the market. If you're lower income or working class, many times even middle class, you can receive subsidies. The government will cap your premiums usually at a certain percentage of your income so that you can afford a basic health insurance plan. You can always opt for a more expensive plan, but you're going to have to pay the difference in those premiums. These types of models are used in the Netherlands, Germany, Switzerland, and sort of kind of maybe other countries as well. But it's purely used in those countries.
Yeah. And then we've got chaos and death, the United States healthcare system. I guess talking about the U.S. healthcare system, I mean, obviously I've called it Frankensteinian before, this sort of bizarre agglomeration of models where, we've sort of got a sort of quasi-managed competition, like public insurance option for the elderly, same thing for poor people, but then we have different like levels of qualification depending on the state and depending on if there's Medicaid expansion. If you're a veteran, we have like the NHS. Got like government managed and run and provided healthcare, but just for veterans. And then we have this, well, we don't have the insurance mandate effectively anymore because there's no penalty for not having insurance. There's still a mandate, but there's no penalty for basically ignoring the mandate.
It's an unenforced mandate.
Yeah, exactly.
Hey,
and so
you need to buy insurance. If you don't, I'm gonna.
If you don't, it's we got some words to share, but and then we've got it. Most people in America who have private insurance get it through their employer, and obviously employers negotiate with however many different insurance providers there are in their state. But then there's also a lot of marginal cases where you can have there's some like state to state level competition with insurers, but there's not a lot of crossover in that regard. And so just a very poorly organized market altogether.
Yeah.
And to be fair, Obamacare, the Affordable Care Act, in theory, like the biggest thing Obamacare did was it just made a lot more people eligible for Medicaid. But the reality is like the individual market and the mandate, like only a very small percentage of people actually get private health insurance plans through the basically ACA markets. Like that basically didn't do anything. It was
we should
mostly
probably break this down a little bit more. Yes, true. It's like 9%, I think, or 10%. It's growing over time. Now, so let's break it down like group by group. So if you're over 65 in America, many people say we have a single payer system. It's actually even more. It's actually still yet not that simple. If you're over 65, we have a hybrid system. So you either have government provided Medicare, or you can have a private plan called Medicare Advantage. These private plans are subsidized by the government, and they are heavily regulated. And so the idea is if you don't like your Medicare, you can pull the subsidies that the government was going to, be investing to lower your premiums and to help fund, take the cost burden off your back. And you can take it and go to a regulated private plan that you might like better. Over 50% of current people that are over 65 are on a Medicare Advantage plan, no longer on government provided Medicare. And one other important thing to note, the Medicare Advantage plans are sold at a national level, which means that if you move and you have a Medicare Advantage plan, you don't you're just not automatically unable to pull the plan with you, which the rest of the system is quite different. If you are like a normal 18 to 65-year-old adult, we have like 4 different systems. If you're poor, you're on a state-based insurance program called Medicaid. And that's only people that are under I think it's 130% of the federal poverty line are eligible for Medicaid. In certain states like Texas, it's like 65%. So you're below, you have to be below poverty to be able to get on this program. Not even some people that are below poverty will be eligible.
Yeah. You've got to be remarkably poor to get on Medicaid.
Like Texas.
Right. Yeah.
And a lot of times there's work requirements. So if you're not working, you can't even get it. So if you have zero income and you don't have kids and you're not disabled, then you might not be eligible. An interesting thing to note with these state-based Medicaid programs is a lot of them are privately managed. So the government contracts out the management of this public program to a private company. That's what happens in California. There's also a similar program for children called the Child Health Insurance Program. This is created, I believe, by Bill Clinton, and it's similar to Medicaid, except it's for kids.
Created by Hillary Clinton, Micah. Don't be a sexist. All right.
Real.
That's true, actually, though.
Oh, I didn't know that. Yeah. Okay. So if you're rich enough to not be on Medicaid, you are likely either on the individual insurance marketplaces or you're on the group insurance marketplace. So if you're self-employed or work for a small business or don't have a job, you just make passive income, you're probably on the individual insurance marketplaces. These are state-based insurance marketplaces that were established by the Affordable Care Act, aka Obamacare. These marketplaces are very heavily regulated. They basically say you're not allowed to charge people with pre-existing conditions more. And they correct for that on the back end by looking at the insurance companies that have riskier patients and subsidizing them and charging the insurance companies that have less risky patients extra to pay for those subsidies. So they're all competing on a level playing field. It's a pretty complicated dance. For people that are, still lower income, but above the Medicaid eligibility, but below 400% of the federal poverty line, you can get substantial tax credits or premium subsidies that will lower your monthly cost. For people that work for large employers, I think it's like 52% of the American population. You get your insurance through your employer. And this happens in multiple ways. You can either have an employer provided plan, or you can have a health reimbursement arrangement where your employer just gives you money that you use, for purchasing other types of health insurance or care. Or there's generally just a huge wide variety of different ways employers can help you out.
And then employers, obviously, I mean, you might go to one employer that has a good insurance plan that you can buy into, and then you might go to another employer that has dog shit insurance, So like you might find yourself, hey, nice pay raise. I got a nice 10% pay raise, but you might go to your employer and find out, oh, well, their healthcare plan is 20% more expensive, right? And that's just kind of something you have to watch out for in America, at the very least, when you're searching jobs, because we don't have premium parity, right? I mean, everyone pays a different premium depending on, all of those assorted circumstances that Mike has talked about. And that's, different than like in, say, the Netherlands, where like at least like nominally, like the bill that you're charged in the Netherlands is going to be the same premium. Like whether you're an 85-year-old adult with diabetes, you're going to pay the same, $200 a month that, a 24-year-old fresh out of like graduate school is going to pay for his insurance. And it's going to be the same plan, right?
Yeah. In some countries, I mean, they vary it by age, but it's really minor and it's standardized. The interesting thing about the American system as well is, we haven't even got through the whole list. There's another individual marketplace, which is the unregulated individual insurance marketplace, which probably shouldn't exist. Basically, a bunch of scam insurances which don't abide by any of these regulations, but don't get any of these subsidies, still exist. And there's plenty of people that still, purchase these insurance.
Someone in the chat asks, do firms compete on health insurance plans, or is it so obtuse that consumers have trouble differentiating the value of different plans? So it's not that. So yes and no. So obviously, like, companies will try to get the best healthcare plan possible for their employees, but that leads to some amount of distortion, right? So like, for instance, if you're like IBM, for example, you're a huge giant employer with like tens of thousands of employees, you're going to be able to negotiate probably a pretty decent health insurance plan. And you're probably going to be able to take the insurance companies for a ride to some degree because you're so big, right? But if you wanted to, work at a smaller business or something like that where they're not able to negotiate as hard, you might just have to, from an employer side, contribute more to your health insurance. Whereas like IBM might say, oh yeah, we'll offer a basic premium-less plan. Like it's literally no premium. It's just a basic plan we offer to all of our employees. But if you're working for fucking Joe's fucking tool shack with 45 employees, you might have to pay $300-$400 a month out of your paycheck in order to actually get the insurance plan as the same level of coverage as IBM employees. And so, and then a lot of the times, like you said, if you're getting a new job, a lot of people just don't think to ask about that kind of thing. Like a lot of people are like me who, you might be 23, 24 years old, not covered by your parents for one reason or another. And you might just not know that that's something to look out for. Like, oh shit, I'm young, I need health insurance, right? And you might end up finding yourself with a job that has kind of shit health insurance that you weren't really prepared for, which, is kind of sucks. So.
Yeah. And just to finish the description, I believe the group insurance market is a national market. So you can centrally negotiate your insurance plan with a provider. And like whenever if I switch locations for IBM, I moved from like North Dakota, for some reason I'm at IBM location in North Dakota, I moved to New York. I think I can keep my insurance. And then there's finally, as Econoboy mentioned, the Veterans Affairs, which is like a government plan program. And the insurance program portion is called TRICARE. And so as you guys can see, it took a long time to go through this incredibly long list. And that takes us to the problems we have in the American system. The American system is extremely expensive. It fails to guarantee universal coverage, and it fails to guarantee universal affordable access to care, right? Because there's many Americans which have insurance, but that insurance has an $8,000 deductible, right? So the cost barrier is still so high that they don't really have access to care. Our system also lacks in quality in certain key domains. We do very well in certain areas. We do very, very poorly in others. And the last thing is, and we kind of hinted at it previously, it produces a lot of economic harm via the job lock effect, whereby the mobility of laborers, the mobility of workers to move between jobs is deeply inhibited by the fact that their insurance and their healthcare is tied to their current employer. I'm going to do some fast facts. Is there anything you want to add?
I mean, that's right. That's a lot of those problems. I think what you'll find, especially, is that like whether SDL was here or not, we would have like broad agreements, right? I mean, typically speaking, when I was going through school in economics, I asked my health economics professor. I was like, "Well, what do health economists think in terms of preferred model for health insurance, right?" And to be fair, what she told me, she's like 90% of health economists would say that some kind of single payer is probably the best system, right? But at the same time, when you go through like a health econ class, whether undergrad, grad school, what you'll find is that there's a significant room for like model flexibility that can guarantee the three main pillars of healthcare, which is universal coverage, affordability, and quality. Those are kind of the three main things that you would look for out of a healthcare system. And when you're talking about, people will say, "Oh, NHS waiting lists and what, all this kind of bullshit that happens in these systems, and what about the coverage gap, and this." And it's like, look, at the end of the day, we're talking about marginal issues, right? Like if you have a heart attack in a Canadian fucking province or, in England or something, you're going to get shipped to the hospital, you're going to get immediate emergency care, and you're probably going to turn out just fine, right? Like these are all quality systems that, are able to guarantee affordable access, and they're able to do so at, substantially more affordable rates aggregately and on an individual level. Look at healthcare spending as a percentage of GDP. And
yes, I have some facts about that.
Look at that. All right, go for it, Micah. Some quick facts.
So let's start with costs. America spends a much higher amount than nations of comparable incomes. A lot of times you see like higher than the OECD average. Let's look at some very rich countries and compare it directly to them, right? So in the case of Switzerland, the United States spends $5,800 more per person. And Switzerland has very comparable incomes to the United States. We also spend a little bit over twice as much as they do per person in Sweden, which is another very rich nation. Despite such enormous amounts of spending, as of 2023, 26 million Americans were uninsured, and tens of millions more were underinsured, which means they had insurance that did not really guarantee them affordable access to coverage. 80% of counties in the United States are classified as healthcare deserts, whereby there is inaccurate supply of providers to meet the healthcare needs of the entire population there. 26 million, 7.9% of the population were 7.9 were uninsured in 2023. So let's talk also about quality. So this is the area where people think that America does the best. In many areas we do, but we have lacking quality in certain key areas. For instance, we have the lowest number of physician visits per capita in the OECD.
But Micah, I thought all these socialized medicine countries have no doctors, and it's impossible to see a doctor in places like Canada and the NHS. What's up with that, Micah?
We actually have far fewer doctors per capita than almost any system.
But I thought in those other systems, doctors don't make shit for money, and so nobody wants to be a doctor. Micah.
It's really remarkable, right? Like Canada has just a bit more doctors per capita. The UK is on the lower side, but we are just so incredibly low. So it is true. Like I imagine, if the UK paid a lot more to its doctors, it would be beating us by a lot more. But our system is just so awful. We pay doctors in this country. I think it's about $400,000 when you take into account all sources of income on average. But we have way lower supply of doctors.
Yeah, and we'll get into that later. But the point is, like, obviously most of the people listening to this, you're not going to be like libertarian leaning or anything. But these are just a lot of people, a lot of conservatives. If you talk to your average family members who are a little bit more conservative leaning, these are the kinds of things that they'll say. And it's just like there's so little evidence that the American healthcare system is a good functional like working system compared to other systems.
It's just very dysfunctional. So like, here's some other facts. American hospital stays are the shortest in the OECD, except for the Netherlands. And the Netherlands is famous for like getting people out of the
I
hospital.
thought
like
in the
that.
NHS they just let people die on the streets though. There's no hospital beds. You can't get treatment on time. What's up with that? I thought that's how it worked, Micah.
Well, the remarkable thing is, you know, I don't doubt that for high income Americans, the American system is dramatically better than the NHS. But like when we look at these averages, like the American system just provides no access to large swaths of the population and almost no access to others,
Yeah.
you know, swaths. So yeah, it's better for some, worse in general by far. So now let's talk a little bit about job lock. We talked about it a bit briefly previously, but you know,
Yep.
whenever your insurance is tied to your job, and leaving your job means you lose your health care, that has a real profound impact on like people's willingness to leave jobs.
Yeah, and this kind of effect exponentially multiplies when you have families. It multiplies especially when you have pre-existing conditions and things like this that can make it more expensive for you to be insured, right? You know, for instance, like when you go to an employer and a lot of their plans will say, oh, you know, your premium for just you is $200 a month. Your premium for you and your wife is $600 a month. Your premium for you, your wife, and your 2 kids is $1,200 a month. Like it exponentially increases. And if you find, it's not necessarily like on its face, it's not a bad thing if you find an employer who has a really good health plan. Like, oh, you know, one of your kids has diabetes and you have a history of cancer and you had cancer at one point in your life. Like, we'll charge you $300 a month and we'll give you pretty good coverage. Like, that's a pretty good health insurance plan in this country for your 2 kids and your wife. But the problem with that is, like, let's say your boss is a piece of shit and your actual pay isn't very high and your working conditions suck. It makes it harder for you to negotiate with your employer on like the actual things that employer is supposed to provide to you, which is your pay and your working, you know, condition, right? So you might have to deal with a dog shit boss for low pay, basically just because they have the best insurance plan. And the only problem with that, a lot of people will say, but wait, but isn't it still good that they're providing a good insurance plan? It's like, yes, but they shouldn't have to, right? That the government or some sort of socialized, like regulated market can provide this better.
Absolutely.
And then you can negotiate better with your employer on your working conditions, right? I mean,
Absolutely. So like, you know, it reduces labor market mobility. So it hampers people's ability to transition from one job to maybe a better paying job where, you know, they're going to be more productive and a bigger contributor to the economy. And it gives employers extra undue power over their employees. So that's double bad, right?
Yeah, and it creates income cliffs as well on the government side. Like, it's not just the employer's fault. Like, imagine you live on a border town between Texas and like Louisiana. You know, Louisiana accepted the Medicaid expansion. Let's say that you live in Louisiana and you barely qualify for the Medicaid expansion, but you get a better paying job across the border in Texas, which doesn't have a state income tax. And now all of a sudden it's like, oh, fuck, like, well, they don't have a state income tax, but then I don't qualify for Medicaid, but it's also a better paying job. And like, you have to do all these calculations in your head. And if you don't, you might find yourself moving across the border within the same country, but a different state. And you might be financially worse off because of how you might or might not qualify for benefits, because we have 50 different ways that we regulate Medicaid, because every state regulates it a little bit differently.
Exactly. Now, I attached a brief section to give the American system credit for the few things that it does pretty well. Americans have much greater access to high-end new drugs, devices, treatments, and services. Our consumption of these things is just at far, far higher rates. If you look at the average age of drugs consumed in the United States, it is much, much shorter than other OECD countries. We also have relatively low wait times for elective surgeries. And like if you look at like the quantity per capita of knee replacements and other procedures like that, it's much higher, which is going to obviously increase spending, and you have to take that into account. Our screening efforts are very robust. In some areas, they're actually world class, and the success rate of our medical interventions is remarkably high. So these are good things. These good things do not explain the difference in spending. They do not require all of this other dysfunctional things, and it is totally possible to maintain or maybe even expand our lead in those areas while making progress.
Well, but
In
Micah,
the other
that's
domains.
the argument, right? The argument is, and I'd be interested to hear your response to this. The argument is, if you have more government control or like government involvement in healthcare, because that's more or less what we're advocating for. We're advocating for an increased set of new regulations in a lot of respects. Like obviously on the supply side stuff, we might argue for some deregulation, but on the demand side, on the insurance side, like the coverage side, we're saying the government needs to, provide more plans. We need to make it more universal. We need to increase access. We had a private conversation where you said maybe in your ideal world, about half of people might be on some sort of public insurance, right? If we had a universal model, which is, that's probably similar to me as well in terms of a transitionary step, right? And so it's like, well, if we have all this extra government involvement, doesn't that just hurt innovation, Micah? Doesn't our healthcare just become dog shit all of a sudden if we do that?
Yeah, well, the thing is, insurance companies are not particularly innovative. They're a middleman. And I think
How
that
dare
private
you?
insurance can add value. I don't advocate for us eliminating all private insurance and banning people from having private insurance. But it is just not all that it's chalked up to be, especially if free market insurance doesn't do anything. It's super inefficient. Like there's adverse selection. You're trying to get the healthiest patients, and like nobody can shop because there's no centralized marketplace. And how the heck are you going to compare all these different plans that have so many different variables, right? So like free markets in healthcare, especially free markets in insurance, don't lead to innovation. They lead to dysfunction and exclusion. And they lead to, in many ways, driving up healthcare costs because so many people get sick, they go to the emergency room and they have to be treated, right, by law, which leads to uncompensated care. So I've organized are the solutions that I think we agree on the problems the American system has, and then we can move on later to maybe talking about the areas where I'm not sure if we agree. The first section is about reducing costs. And so I think one of the most underrated ways to reduce costs in the American system is to establish a unified national automated claims clearinghouse. That sounds really complicated, but it's really not. If you are a provider and you want to say, hey, I provided this service, let me put out a claim there so the insurance pays me for the service I provided. It is really, really complicated in the United States. It is a much more complicated system than it is pretty much anywhere else in the world. You send that to a contracted clearinghouse, like a third party that's supposed to take this. And then they, in many cases, send it to another clearinghouse, which maybe then communicates with the clearinghouse that your insurance wants to use. And sometimes you have three intermediaries here. And each one of these has to look at every claim and authorize it and verify it and transmit the data. It is not efficient whatsoever. It's not even fully automated. There's like a lot of manual labor in this process. So by switching to one national clearinghouse and having everybody in one system, just like what we've done for finance, you would dramatically reduce the actual administrative cost of billing insurance.
I mean, we're talking about, like, again, what do all the capitalist stock investors do? They use a universal clearinghouse, right? I mean, they realize, hey, the private market in a decentralized fashion is probably not the best way to handle something like basically just a transaction cost, right? Like having some sort of universal system is probably better. That's what all the innovative billionaire stock investors who are, the perfect libertarian, ideal, rational investors, that's what they do. So, maybe healthcare could be a good realm to to take that model. And, I've heard, well, we don't have to get sidetracked, but in general, like sometimes centralization in a market makes things more efficient,
Sure. No, and, just that reform alone could reduce administrative costs significantly, but there's plenty of other things we can do, right? So we can require universal interoperability of medical information systems, and require that every provider basically shares information with other providers. And, that's why it's one of the biggest strange things that I think consumers see in the American healthcare system that you don't see in other healthcare systems. Your doctor needs to ask you for the same information every single time you go somewhere. You have to fill in an intake form. What's your name?
Isn't that the worst? Jesus.
And the thing is, We have to do it, and then they have to input all this information. Not only does it take a bunch of, cost a bunch of money, but it also leads to worse healthcare decisions because many times doctors aren't making the most informed choices. And at the aggregate level, all of this healthcare information is very useful for providers and insurers, and in this, also the government in shaping healthcare policies so that we're really doing what's most effective.
I mean, how often do those forms go 10% filled out because you just don't want to fill it out for like the 100th time at a different provider, and you're not giving all the information to your doctor that you're supposed to, right? It's like just a really stupid inefficiency in our system.
Yeah, we have accountable care organizations, which are just like all these providers which agree to share information, and these are supposed to be like there's all this data, like, oh my god, these are so much better. Like look at how much better the healthcare outcomes are. Meanwhile, like the entire healthcare system in these other countries is in a accountable care organization because they all share information with each other. So like that's just complete common sense. Another thing is, so because our insurance system is so fractured, the actual coverage of different things is not standardized. On the individual marketplace that was created by Obamacare, everything is very standardized. It's modeled after like the systems like in Switzerland and the Netherlands. So I think if we move more people from the employer insurance market and really even standardize those packages a little bit more, it would help providers dramatically because they wouldn't have to spend so much time haggling with insurers after the fact about whether this thing should be covered or not. And, and how much money they can get reimbursed for, doing XYZ service.
Exactly. Yeah. And I mean, on on some of the stuff that might make healthcare less expensive, some of the things that we talked about were, we mentioned briefly, like these supply side reforms, people will oftentimes like vaguely reference these things, but like talking about specifically what it is, right? So there's this organization in America, pretty much every country that I'm aware of has some sort of like professional organization for doctors and medical professionals, right? So we call it the AMA, the American Medical Association. They are essentially a professional organization of doctors and various medical professionals that tries to, in theory, like set good standards for what it means to be a doctor and, standards of care and things like this. And, for the most part, there's a reason why every country has something like this, because it's a good thing to have professional standards for like every profession, whether you're an electrician or you're a doctor. Just generally, it's probably a good thing, right? It's not to say that you need like these strict certification requirements, but having some sort of guidelines is probably good. And the problem, however, is that the AMA is also a lobbyist organization, right? Like they lobby for the interests of doctors and medical professionals as well. And so what that's led to, at least in America, is not only a history of the AMA advocating against universal health care. In Canada, for instance, famously before they enacted their Medicare system, their version of the AMA was like, please, God, don't introduce the fucking Medicare system in Canada. It'll be terrible. It'll hurt doctors. Nobody will want to be a doctor anymore. And then it turns out everything worked out just fine.
Doctor pay in Canada is actually pretty high.
Say again?
I believe doctor pay in Canada is still pretty high by national standards.
That's the point, though, is that the AMA will say, and some of the regulations that they've lobbied for instance, is like a cap on residencies. So, when you want to become a doctor in America, you have to do a 4-year bachelor's degree, which a lot of other countries don't even, you just go straight to medical school after high school, which is probably something that would make sense. But you have to add on this 4 years of undergrad, so between, let's say, $10,000 and $50,000 of expense, depending on where you go. Then you have to actually go to medical school, where you do 4 years of medical school, but unlike a lot of other systems, you don't do your residency in medical school. You do 4 years of medical school, which costs $250,000, and then you have to apply to residency programs, right? So you have to take tests and basically pass medical school. Then you apply to residency programs where that's almost like your apprenticeship period, right? You do rotations when you're in medical school, then you do your sort of formal apprenticeship when you're a resident. And some residencies take a really long time. Like the minimum is 3 years, but if you're becoming like a neurologist, that can take up to 7 years. So by the time you're in your mid-30s and you're becoming an attending neurologist, yeah, you're making $500,000 a year, but you're not making that until you're in your mid-30s, right? And the number of residencies is capped. So you might find yourself wanting to be a neurologist, but you just can't get into a fucking neurology program. So a lot of times people will take gap years between undergrad and med school because they can't get into med school, right? But then they'll take gap years between med school and residency because they can't get into the residency that they run. And so they might funnel into other residency programs and things like this. And all of these things are capped, right? There's like literal legislative caps on these things. So we have a limited number of doctors that we can have in this country because the AMA says that's how you maintain like the quality of physician, but really it just maintains their salaries. They operate like a cartel essentially, right? Micah, go into it.
To be fair, now they talk about this physician shortage, although like their solution sometimes is giving more subsidies to physicians. I mean, who would have thought? Yeah, you're completely right. I mean, one of the biggest issues with our healthcare system is we have huge supply bottlenecks, specifically for the supply of physicians. Maybe it's true for other medical professionals as well. In Germany, they have 65% more physicians, right? And we already established in Germany, they pay their doctors significantly less. I think it's like 50% as much or something like that.
Like it sounds unintuitive, but like when you look into all the requirements to be a doctor in America and you compare them to other places, it is simply too hard to be a doctor. It should be easier to be a doctor in this country. And the idea that a country caps the number of doctors that we certify each year seems like most people would think, why would more doctors be a bad thing? Like most people would have that intuition, but the AMA does not share that basic intuition. They say, no, we need to cap the amount of doctors that we have because that's better for quality of care. Of course, really, it's just better for physician pay. It's not really better.
Yeah,
the
it's
residency
awful for quality
system.
of care. I mean, you've seen that when people spend less time with their physician, the likelihood that they are given the wrong medicine or they have their issue not treated increases dramatically. We have a very bad primary care system in this country compared to what is possible because we don't have enough doctors. So people are going to specialists or waiting till the last minute and getting all these extra procedures they shouldn't get because they didn't have a primary care doctor, which could, really do preventative medicine. In unlocking those bottlenecks, uncap in the legislative cap on residencies and invest in increasing medical school seats dramatically. So just to increase our per capita level of medical school seats to the German level, it'd be a 45% increase. And then we also have to increase it dramatically already because healthcare demand is growing. People are getting older. They're needing to see their doctor more, and our population is growing. So we really need to aim to like 45% plus over the next 10 years. And that's going to require a lot of. We also should make the process easier and shorter. So in Germany, it's a 6-year process. You go in directly after you graduate from high school. It's like 2 years of like preclinical training, 3 years of clinical training, and then the last year is internships. If you want to be a general practitioner or a primary care doctor, at the end of your school, you take your licensure exam, and then you're licensed and you're ready to go. You can go become a primary care doctor like that. For the people that want to be specialists, they take their licensure exam, then they have to go do residency, which I think residency is fine. It's also free. And that means that, you don't need to get paid as much on the other side. You're getting paid partially on the front end, and you're not taking on $250,000 of student debt, which is really stressful and leads to some people just dropping out and being, in a state of financial precarity. So increase the supply of doctors. Also expand the scope of practice for nurse practitioners. We see that in different states, there is different rules about what physician's assistants can do and what nurse practitioners can do. What we don't see is that there's a difference in quality. So
really quick, what Mike is saying, don't ask your doctor friend. I have a couple doctor friends, and when you talk to them about nurse practitioners, it's like Hitler talking about Jewish people, okay? Doctors hate nurse practitioners. It's like they're dog shit. They don't know what they're doing. They shouldn't be able to prescribe antibiotics. This is ridiculous, right? But it's, again, like when you look at the literature, when you look at surveys of people, it turns out when it comes to basically just getting checkups and very basic prescriptions, like nurse practitioners can handle that. You don't need a guy who's 35 years old, 15 years in his educational journey in order to do basic prescriptions like this. And a lot of basic procedures as well could probably be compartmentalized. Like physician's assistants is another example. Like people think that when you get surgery, it's the surgeon doing most of the work. Well, it's actually a physician assistant doing most of the work. And the idea that, hey, a physician assistant should probably just be able to supervise surgeries by themselves without a surgeon just kind of standing there and doing nothing. Like, that's really not that radical an implication when you understand, practically speaking, that's how a lot of healthcare is delivered anyway in this country. So
Yeah, and like there's a lot of really minor surgeries, like you want to remove a lesion or a mole or stuff. Like these are things that these other medical professionals, which require much less training and are much cheaper to train, can do. And by increasing the supply of these folks, we can reduce our healthcare spending dramatically. One of the biggest drivers of our healthcare spending over time is the fact that these insurance companies want to give their enrollees adequate access to care. And so what they do is they raise the premiums for these enrollees in order to try to bid up the price for these different medical care providers. Hey, I'm going to pay you this much so that we can have this much access. And well, what happens? Well, they all do that. And so the cost goes up and up and up. And since people are not very elastic to their premiums in our system, there's like nothing really containing it. The costs just go to the moon. There's tons of other stuff we can do. So on the individual insurance marketplaces, there is multiple different tiers of coverage. There's bronze coverage, which is like catastrophic. There's silver, which is less catastrophic, but still there's big deductibles. There's gold, which is pretty solid insurance. And there's platinum, which is like you're like almost overinsured. Like you have barely any cost sharing whenever you go, attend a doctor, very low deductibles, very low copays. And so I think that we should eliminate these tiers and have one tier or maybe two, gold and above, because these tiers make choosing an insurance plan unnecessarily difficult. A lot of times people look at the cost. They just look, oh, I want the lowest premium or I want the lowest deductible. These are really not the things that we want insurance companies to be competing on. We want them to be competing on, what network they provide you and how high their premiums are, and these other types of varieties while standardizing certain things, making sure they're all giving you affordable access to care. And by increasing that standardization, you increase the competition over the variables that matter.
Right, and that's a good point as well. I mean, again, insurance companies don't really, or like Micah said, like insurance companies can only add like so much. In theory, the value of an insurance company is the administrative efficiency. In theory, right? It's the ability to clear payments out, provide a basic plan, obviously create the pools themselves, and reimburse people. But just offering like a fitted sort of deductible plan on somebody probably isn't the type of value creation that we would really want, especially when we think about a lot of the financial implications of plans like that are basically that there's just a lot more people in financial distress than otherwise is there. One fact that Micah didn't mention is that medical bankruptcy just like doesn't exist in most of these countries. That's just not a thing that happens. It doesn't happen in those countries. Whereas in America, some crazy high percentage of bankruptcies are basically just because somebody got sick. Basically because somebody got cancer and their insurance is dog shit, or they lost their job and they don't have insurance, or they find themselves uninsured for, because they're in a coverage gap or something like that. And they end up with, or the most hilarious circumstance in American healthcare, you're insured and you have good insurance, but you happen to go to a hospital where one of the doctors in that hospital is not in your network.
Prize billing.
So because the doctor who you had no choice over performed your appendectomy, now all of a sudden you have like a $60,000 bill when your insurance in theory should have covered the whole thing. We didn't talk about in-network versus out-of-network, but like medical bankruptcy and financial distress due to medical costs is just something that is so pervasive in the American system. I mean, how many news stories can you find about like, couples doing these crazy asset management schemes where it's like, oh, I got cancer, so I shifted all my assets into my wife's accounts. Then we had to get a legal divorce and we had to be separated for a number of times. That way that I could go bankrupt and that way all of our assets were secured. And it's like, good God, why can't we just let this guy have cancer, go to the doctor, get medicine, get treatment, and then not worry about like anything else, But our system puts so much financial distress on people that when you have people picking, high deductible plans and things like this, and not to mention all the coverage gaps we mentioned, we just end up with a lot more financial distress due to medical, basically medical bills that just shouldn't exist. And then from a moral perspective, it's like, guys, does it just sound morally like the best system, right? Like even if it was true that we get 1% more medical innovation because we have so much inequality of access and private options in our healthcare system. Is it good that we have so many people who are like stressed about money while they have cancer? That just seems
But it's clearly
bad,
not
right?
utility maximizing. Like it's just so. I mean, like I guess you could use like a 1,000-year time window. It's like, well, even 0.01% medical innovation effect.
Right, exactly. I mean, it's
not true.
very and so many people in America have personal stories like this where they were either born with some condition or they happen to get cancer or they got hit by a car or something, and you just end up completely I mean, like a guy like me, right? I'm very sort of financially studious and save all my money and save for retirement, like, and I have insurance and I have a decent employer insurance provided plan. If I got cancer, I would be fucked financially because I just don't have like tens of thousands, hundreds of thousands of dollars to like pay for that care. And unless you're in some sort of like capped model or something like that, you're still going to end up with tens of thousands of dollars in bills, even if you do everything right. My grandma, she had a union insurance plan, which was a very, very good insurance plan. Her husband got cancer, and she still ended up, after he died, she still had $20,000 in debt that she had to pay, even with insurance that whole time, even with a good union negotiated insurance plan. And that's just fucking ridiculous.
It's not adequate. And
Yeah.
in many cases, people don't end up being able to pay. And then you have uncompensated care for the providers, which means, those providers have to try to either raise the cost for everybody else or they close. And that's why you see, I mentioned previously, healthcare deserts. Where are these? These are in rural areas where there's a lot of uncompensated care, and they're in poor areas. And that's just awful across the board, right? Not having access to healthcare is unacceptable. It's not, necessarily.
Yeah, a significant portion of care is just written off, right? I mean, like the best financial advice, legitimately in America, the best financial advice, if you have a medical bill you can't pay, is just not pay it, right? Just don't pay it. Let it go to collections. Oh, your credit you get 20 points hit on your credit. Who gives a shit about that, right? And then let's say 10 years down the line, you're able to pay it off. Well, you call them back and you pay it off for like 10 cents on the dollar. Your $30,000 bill becomes $1,500. For goodness sake, I mean, how many stories do people have like this? Like, we had a situation where a family member had to have a heart surgery. They said, oh, well, your bill's going to be $40,000. And then they said, well, we literally are just not going to pay that. We're not going to pay it. Fuck you, right? And then the insurance, and then during that same phone call where they're like, the bill's 40 grand, that same phone call, oh, you can't pay it? Well, how about 7 grand? It's like, how the fuck, how malleable are these? Are these just made up like fucking play prices, you guys? Like, that's just how ridiculous our system is, where your best advice is to not pay your bill.
And it's not efficient, and it produces excess costs all across the board. We're almost done with this section.
Goodness.
Yeah, by having more standardization on the individual marketplace.
Section. The expensive
Yeah,
part.
It is. It is. Are you on the dock?
I am. I'm following along, Micah.
Yeah. So by having more standardization of these plans, and that means saying, hey, this is what the deductibles are going to be, right? Hey, every plan's going to cover, dental. It's going to provide a dental plan, right? Standardizing these areas where there's not really value add from variation means that there's more intense competition over the things that do matter. So people will look, okay, I'm going to have to pay a higher premium here. Am I going to get a good deal in terms of it covering maybe more treatments, services, drugs, products? Is it going to give me access to nicer providers? This is the kind of thing that we want insurers to be competing on, not on who can, have the different cost sharing plan here and have a slightly lower copay there. That stuff is confusing. And honestly, because consumers are not really well versed enough to look at these entire plans, they're not interested in doing it. It just leads to an inefficient allocation of people to plans. Okay, here's a really big one. And I included a map or in the chat for us to share. Certificate of need loss. So there are many states in this country where, in order to open a new medical provider, a new hospital or doctor's office, or expand an existing one, you need to get a certificate of need from the government. You need to basically provide them a application that says, hey, this is why this thing should be allowed to open. And government bureaucrats, after looking over it for a long time, can determine whether you are allowed to open this new provider or not. And so at best, it increases the cost of opening up new medical providers, which reduces supply and drives up costs for everybody and reduces access. At worst, they just say no. And when they just say no, well, that feeds into market concentration. In a lot of areas in the United States, there's only 1, 2, 3 different kinds of providers for a specific kind of medical care. And well, that's really bad, because whenever you don't have very much competition, guess what happens? Prices go up, even when it comes to medical care.
Yeah, it seems like kind of, again, it's just one of those things that seems ridiculous on its face, and it is ridiculous. The problem is that most people just don't know about stuff like this that happens. Like the idea that, oh, like we have to have a government bureaucratic committee process to determine if we want to build a hospital. And again, we have to be clear, these are circumstances where people have come together, investors, nonprofits, like, localized entities come together and says, we want to build a hospital. And then the government says, well, we got to make sure we need a new hospital. And it's like, but guys, is there basically ever a case where building more hospitals is like a bad thing? I guess in theory, you could have a shitload of just empty, rundown hospitals. But like practically speaking,
like no one's going to open a hospital that's going to lose money, right? Like nobody's trying to do that.
Right. Like, so, there's no, yeah, exactly. Like, this is ridiculous, right?
It's like, should we maintain our current shortage of hospitals, or should we allow some provider to resolve it?
Yeah, and when you look at these states, of ones that don't have certificate of need laws, it's not like Texas is just drowning in hospitals. It's just one less bureaucratic step that marginally increases the supply of healthcare facilities, right? That we should probably get rid of. So.
Yeah, and in some states, I mean, I think they have much more of an outsized impact than others. Like some are very draconian, some are not.
I've heard New York is pretty bad. Like if you look into the specifics, I mean, New York. I mean, for God's sake, New York used to have, this is crazy, guys. New York used to have a law that said if you want to be a practicing physician in New York, you had to get your medical degree from New York, like a Texas trained. Like if you went to medical school at UT and you've been a trained physician in Texas for 25 years. You couldn't practice in New York State. They had to get rid of that because of COVID, because there was such a shortage and such a constraint on the system. So, they had to get rid of that completely ridiculous policy, but they still have certificate of need laws, and there's other, these sort of, I call it healthcare NIMBYism. Thing. Yeah, exactly.
We did this for pilots. I mean, we should require mutual recognition of licensure for medical professionals that meet certain minimum standards, and those standards will be low enough that every licensure system will meet it. Here's another thing. So we have market-based pricing for emergency care and ambulance services. Now, I don't know the last time you guys shopped on the market for the best ambulance deal, but this is not a place where markets work at all. There's no competition. There's no shopping. There's no reason why this should be a
And by the way,
thing.
even if you did, because here's the thing, how many stories are there of people who say, I told them in the ambulance, don't take me to this hospital. You have to take me to this hospital because of my insurance, even though it's further away. And the ambulance drivers are just like, yeah, we're just going to take you to the closest one because obviously you're about to die and we can't just spend an extra 10 minutes in traffic because of your stupid ass insurance plan. And to be fair, they're just doing what they think is, they don't want this person to die, obviously. They just want to get them access to care as quick as possible. But because of our stupid ass system of healthcare and insurance, which no other country in the world has, you might just end up with a shitload of fucking bills after a near-death experience, which is kind of a slap in the face, right?
It's ridiculous. So we should just have a central negotiation. In many countries, they essentially negotiate all services and drug costs, stuff like that. At a minimum, we should centrally negotiate the charges and fee schedule for emergency care and ambulance services. So definitely agree on that.
Yeah, for sure.
That would save money.
Yeah, and that's obvious. I mean, come on, guys, come on, libertarians out there.
So let's talk a little bit about FDA reform. The Food and Drug Administration, the guys who approve and look over all of our drugs. One of the most common sense things, you've heard this probably proposed many times in the past, is that we should allow drugs that have been approved in other trusted nations, like EU approved drugs, to come into the United States without having to go through the same FDA or very similar FDA approval process all over again, which is extraordinarily expensive and takes a lot of time.
Finn in the chat says, without a market, how will you know the prices? Checkmate, commie. So just describe briefly, like, how would you negotiate these prices on ambulance services and emergency care?
I mean, I would do it just like what other countries do. I mean, there's basically two different approaches. One is the government negotiates with the providers, and it basically says, okay, like, hey, what is the cost of production here? Okay, we're going to set it with you with this margin.
If I really quick, to describe this a little bit more granularly, what this would typically look like is like there would be like an association group of like ambulance providers or like emergency care providers who would put people on a committee, and then the government would they would appoint government people to half the committee, and then this appointed industry group and the government would negotiate these costs and, you know, come out with schedules each year. Exactly. Yeah.
And you know, the alternative approach, and this is what they use in Switzerland, is they have the insurers negotiate. So the government's like hands off, maybe like the government's in the room, but it's mostly the insurers and the providers kind of hashing this out. And
just sort of
we could do either
facilitating the process.
Yeah. I mean, either or is fine. And you know, they do this across the board. This happens all over the place. It's not like there's a shortage of emergency care in Switzerland, and or maybe there is. It's not like there's a shortage of emergency care in all of these countries, so it can't work. Okay, now we get into the more kind of radical proposals about FDA reform.
Oh shit!
So the FDA is famously very expensive for companies to successfully go through their trials. It takes very long, and it's famously risk averse. Basically, they will reject drugs, even if they come with a small risk, with lots of reward, because they'd rather, you know, 3 people die because they didn't get the medicine than 1 person die because they did. And so this very risk-averse model, people say, is very problematic, and they say the FDA is very inefficient. And so there's a couple different proposals about how you can reform this. The ones that I'm cool with are opening up some drug approvals to private medical boards, maybe with government facilitation. This is what they do in the EU. So you can take like lower risk drugs and have some alternative boards that are available to go review these drugs. So there's maybe some competition among them, and the highest risk stuff goes to the FDA.
The Libertarian European Union uses private organizations to approve their drugs. That's what I'm hearing, Micah.
So true.
I mean, to be fair, have you looked into something that I've always thought just kind of intuitively made sense? This idea that, because I talked about how absurd it was, the idea that a New York doctor has to be trained in New York for so many years. But I also feel like it's crazy that like drugs that are used and approved in Canada, or like doctors that are trained in Canada, they have to go through the same approval. They have to redo their approval processes in America.
Yeah, that's what I'm saying.
So like if you know, I feel like in theory, right, if you're a trained doctor in Canada, we should probably trust that the Canadians are training their doctors pretty well. And if you're a Canadian doctor, you want to move to the US, just let them on in. But oftentimes, if you want to, you know, do that, you have to redo your residency and redo a lot of training. Like if you're a 45-year-old doctor in Canada, you probably don't want to redo all of your fucking certifications and get paid like shit like residents do just to move to America. And the same thing with drugs. Like if Canada approves, you know, a heart medication that they find to be really effective, it probably makes sense for that drug to have like a significantly expedited approval process in America, or to simply just have like an international sort of rules-based approval process where it's just automatically approved, you know, given certain countries have already approved them.
Yeah, with the regulatory reciprocity agreements. Yeah, that's what we should do. And I think for licensure, that's a good point. Like we should say, okay, maybe you need to take some sort of like mini licensure exam just to like bring you up to date on specific American medical things that you might not know about since you're from Canada.
Not literally redoing your whole residency, which is basically what you have to do here.
Sense.
Yeah, of course.
Okay, so are you cool with the medical boards thing? You think that's a good idea? I think it's a decent idea. I think it probably helps.
You know, I don't know how that kind of thing would be set up. I mean, maybe, you know, it doesn't sound like...
Another idea is free to choose medicine. Basically allow people to purchase medicines that have gone through preliminary safety trials, but not like significant efficacy trials. So it's not like these things are cyanide. Like you're not going to just die, probably. And
didn't Trump do that? I thought he signed some right to try a bill. Or
yeah, but
like
it's
that.
not there's tons of things that you don't have a right to try. So most of those executive orders were, you know, not effective. Didn't do anything.
Virtue signaling from the Trump
I think that's
admin.
fine. I think if it says not FDA approved, like has not been tested very clearly in the box, Like that's fine. You know, there's a lot of stuff that gets rejected by the FDA, which is ridiculous. Like for diabetics, I'm a type 1 diabetic. For type 2 diabetics, they take this medication called metformin, which increases their sensitivity to insulin. So whenever they take insulin, that insulin, you know, really has a big impact. For a lot of type 1 diabetics, they struggle because they'll get very insulin insensitive. The medicine is not really working as effectively as it should be. And so they want to be able to take metformin to increase the efficacy of their insulin to help them manage their blood sugars and be healthy. But the FDA was like, yeah, we're just not going to allow you guys to get metformin, or at least it was a specific version of metformin that was trying to be made available for diabetics. And like, what the hell, right? Like that's an area where like free to choose medicine just allows people to like consume drugs that they clearly like, the FDA clearly messed up on.
Yeah, unfortunately, I feel like the FDA, like saying you want the FDA process to be easier is almost, it's almost like people in their minds go to like fucking 3 Mile Island when you're talking about nuclear energy. It's like, what do you mean? But the FDA messes up sometimes, and like we need all this regulation, and my God, shouldn't it be the hardest thing in the fucking world to get drugs approved? And it's like, well, guys, all we're saying really functionally is that it's just too hard. We should probably make it a little bit easier to approve and access drugs.
I think there should be checks, you know, like that's why I think private boards are okay. Just ways that we reduce the risk of like overregulation. Just because, you know, people in the FDA, do they get credit whenever they approve a really good drug? No. They do get the blame though whenever people die because they approved a bad drug. And so ultimately, there's going to be a constraint on how good the FDA is going to be with these things. But by incorporating other systems where we can kind of get more of those lower risk drugs through, we kind of minimize the negative impact.
What do you think about making like parts of Operation Warp Speed kind of permanent? Like one of the biggest things about being able to create a vaccine so quickly was that a lot of the processes in the FDA are step ladder processes. Like you do this, and then you can do this, and then you submit that data, and then you do the next step, right? Whereas Operation Warp Speed basically said, yeah, if you got the money, you can just do all that shit at once, right? You can do all the stuff at one time. You don't have to like wait for approval on each step. You can just do every step at once, and assuming you've sort of collectively met all the steps, then the drug gets approved, like something like that.
That sounds like an amazing art. I have so many articles I'm working on. Make Operation Warp Speed permanent sounds like a banger article.
That was one functional part of Operation Warp Speed, was it allowed drug manufacturers to concurrently do all of the steps of the FDA process instead of sequentially. Warp speed. Yeah, permanent drug warp speed. I mean, unironically, like that is legitimately one of the best things Trump did as president was Operation Warp Speed. Like, it seemed like it was
vaccine. I did the vaccine.
Legitimately,
I killed COVID.
Legitimately, Operation Warp Speed was, and to be fair, I don't think Trump is like designing this executive order or something, but like his administration, that was a really good thing that his administration did. And I think some lessons to be learned from that is like the bureaucratic process of the FDA is just, it really probably is too bureaucratic. It's too ridiculous.
If I didn't do Operation Warp Speed, so many people would have died. You know, it's just like, it's amazing how he was kind of a pro-vaccine.
While his supporters are screaming that the vaccine doesn't work and booing him for...
We're near the end of this section. Consolidate public insurance programs. Why do we have state-based Medicaid programs, state-based CHIP, public employee plans which are publicly managed, and then Medicare? Why don't we have one unified administration in CMS and Center for Medicare and Medicaid Services, and they administer it?
I don't know, Micah. Why don't we just have one brand of deodorant? Why don't we just have one car? You think that would work? You think that would work, just having one car, Micah? Why do you want only one insurance plan?
There's so many benefits to this. Like, first, we could get rid of all these different state eligibility requirements that keep poor people off of insurance and are one of the leading reasons we don't have universal coverage at this point. It would increase the efficiency. Medicare is always trying to experiment with new ways of paying for services that are more efficient and new ways to reduce their administrative costs. Well, now that's going to be true for everybody. You don't need to have a separate Medicaid program, which does all the same research and is administered by some like private company with this complex contract bidding process.
But Micah, explain. I think that's actually important to explain, like, because some people will say, why don't we just do this with cars? Why don't we do it with fast food places? Why is healthcare different? Why is this centralization of service and coordination of service, why is that uniquely advantageous in the healthcare market, and why wouldn't we do that in other markets?
So, like when it comes to insurance, especially health insurance, there's just a ridiculous amount of market failures that make like a super competitive, like tons of small insurers just completely unfeasible. And there is increasing gains to scale. The higher the scale, the lower the administrative costs are going to be. And whenever you have multiple public programs, like why would you have, it's not like it's a market, like it is different government programs that just have different administrators, different research arms, like they have different reimbursement rates. So the providers have to like,
Well,
just
but you said
negotiate with
private
each one.
plans. You said private plans should be standardized as well, though, right?
Sure. Well, because there's so many different ways in which, like whenever you shop for a car, there is variations in things that like are easy for you to understand and like matter, right? So you can say, okay, what tier of car do I want? Okay, like there's multiple tiers that are valid. It's not like buying a Honda Civic is wrong. Buying catastrophic insurance is like bad. Like we don't want anybody on such like high deductible plans because they're not insured properly enough and they're not going to get enough care. Right. So like many variations when it comes to health coverage are just bad. Like not having dental coverage is bad. Not having drug coverage is bad.
Like when an insurance company says, oh, you have access to our network and it's like, in theory, you could say, well, which insurance company's network is better? But really, I mean, technically speaking, if a hospital is in one network and another hospital is in another network and they're both local hospitals, like, how does an average person really know which hospital has better care? It's very difficult.
I think that's something like whenever we look at observational evidence, you do see that people are somewhat sensitive to networks. If you get rid of all this other information, which crowds this out, right? So if I like know, oh, Memorial Hermann, that's the really nice place with the really nice facilities. Oh, they're covered by this insurance. Like, I think that's fine competition, right? Like, oh, this insurance.
Yeah, but that's the point though, Micah. Like that's not like the libertarian ideal where like the consumer is making a technical evaluation of service. That's like just relying on brand equity and word of mouth, right? Whereas when it comes to picking a car, it's easier for most people to look at the features of a car and say, well, I want this feature because it's strictly better, like miles per gallon, right? Well, this vehicle has better gas mileage than this vehicle, therefore this vehicle is better in this way. Right, whereas
valid.
Exactly, right. But when you're talking about healthcare, like it's the same reason why people have to rely so much on word of mouth when it comes to like electricians, because when you're looking over an electrician's shoulder, you're not going to know what the fuck they're doing and if they're doing a good job, right? Because you're not an electrician, right? And similarly with providing healthcare, most people, it's just not clear that people are as able to choose quality healthcare accurately as other markets, right? That's something that differentiates healthcare to when people say, oh, like this is a gotcha that people will say, why don't we just do this with fast food? Why don't we do this with pencils? Why don't we do this with every other fucking thing? If you're saying centralization's so good for healthcare, it's like, well, yeah, because I'm not a dumbass. Markets are different. Markets act differently, and different products are probably better oriented for more and less free market positions, right? But when we're talking about healthcare, the breadth and depth of the market failures is what justifies pretty much every other country on the planet deciding we need these types of centralizations, these regulations, these minimum coverage standards, in the healthcare market. When the UK has a very centralized healthcare system, notice in the UK they still have competing car manufacturers, and the government doesn't decide, well, we centralized healthcare, so we have to centralize every other thing because that way, like governments aren't as stupid like that.
Like economic planning, regulations or expressions of plan, they're not as extreme, right? Or like complete government control, that's extreme planning. Is dysfunctional. It's not perfect. It doesn't like lead to utility maximization. Markets are not perfect, right? And we look at different sectors and we decide what share we need. If markets are working super well, free markets, let's go. We should do that with housing. The planning is not working very well. But in some sectors, like markets, like damn, markets suck. So the debate becomes, okay, should we regulate them a lot or should we just not have them? For like insurance,
it's important for anybody listening or for anybody who wants to argue this with other people to understand that like, of course, we all have our own ideologies. Obviously, SDL is a socialist, and Micah's a more of a liberal sort of center left person. I'm a more progressive social democrat, I guess. But like, we would all, typically speaking, recognize that, like, on an industry level, it doesn't make sense to be like so ideologically motivated. That there's different models that work better and worse, right? And that it doesn't make sense to just be like, I'm a libertarian, so I think everything should be privatized. Like, what you'll find if you so ideologically evaluate problems in society is that you just end up with like not a very good fitted solution, because it's like, hey, well, what about this problem? Like, if you're a committed like communist who thinks that we should centralize everything, right? You're like this Soviet Union style communist. It's like, yeah, but what about all the times when that just doesn't work? Right? And why is it so much better when we have more private distribution of goods? It's like, you can't answer that question, because it turns out the best economic model is just kind of asynchronous, and it depends on a lot of different circumstances.
The world is nuanced, and it doesn't fit. Like, there's not one size fits all solutions to all problems. And here's something that I should say to the right wingers that are out there. You guys disappoint me so much on healthcare. You guys hate on Obamacare. Obamacare was modeled
Micah's not
after
mad. He's disappointed.
It was modeled after the most successful right-wing healthcare system in the world, Switzerland. That is as right-wing pretty much as you can get while being functional. Singapore is to the left of the Swiss system. They have government insurance there. So Switzerland has fully private insurance. Everybody has private insurance. It has subsidies for the poor. It is very regulated. It's an individual marketplace. That is literally what Obamacare was largely about. And so you guys, if you want to be right-wing in healthcare, that's fine. There is evidence. There are arguments. Go support the Bismarck model, aka managed competition. Get out of here with this clown, like, oh, we shouldn't have universality, actually. Like, not covering the poor, that's actually bad, you know? Everything is because of the government's regulations. If you just deregulated con laws and you got rid of these licensure requirements, now healthcare is so cheap that everybody will have access. You're not fooling any of us. Okay, there's a reason why no healthcare economists agree with you, because you're wrong. Okay.
All right. What's the next thing, Micah?
So there's only two other things left in this area: strengthening antitrust action to prevent market consolidation. So this is like not a one size fits all thing. I think like people like Elizabeth Warren and Bernie maybe think like you can drive down prices an incredible amount doing this, but in some areas there's genuinely basically a monopoly, or future mergers that are going to produce monopolies for certain kinds of care, like hospitals. That's bad, right? And we should use.
Can you give an example?
There's plenty of rural areas where there's only one hospital in the vicinity, right?
Okay.
Or maybe there's two, and they're saying, "Hey, let's merge." And I think the government should use its antitrust tools to apply a great degree of skepticism to such mergers, and in some cases, break up consolidated healthcare systems.
Like what is Blue Cross Blue Shield's like market capture?
Well, that's for insurance. Like really insurance is like. So that's going to get to our next session, how we fix the insurance thing. But the other thing is banning price discrimination among insurers. So yeah, like as you mentioned, there's a lot of really big insurers in this country. They are very, very large. And it's because they are able to use their bargaining power to have larger networks and to get lower prices. They say, hey, we have so many patients, you need to really negotiate with us, because if you don't accept the prices that we're offering you, Medicare care providers, well, you're going to lose out on all of our patients, and it's going to suck, right? And so the bigger the insurer, the more bargaining power they have, and the lower the prices they can bargain. And so, well, this is bad because it disadvantages startup insurers and reduces competition. It also leads to prices which are completely irrational. Like many times they bargain prices that are not really at cost. They're below cost for certain services, which creates tons of provider distortions. Now they're not wanting to provide as many of these services anymore. And like the volatility and variation amongst healthcare prices in this country is ridiculous. One payer at a provider at a hospital pays $200 for MRI. The other payer pays $6,000. It is insane. And so if we tell the providers, hey, you got to charge all insurers the same rate, that eliminates the ability for people to use their market power to give themselves an unfair advantage and streamlines the system and makes provider decision making much more efficient.
Right, and this is where what Micah mentioned earlier, where in theory you could have the insurance companies sort of in a decentralized fashion negotiate these costs, where you could have a similar sort of providers committee appointed people talk to a insurers sort of association appointed people on the same committee, and they could just set these rates on a yearly basis. The Canadian system, like you can look at their reimbursement rates, like this is just a sheet they come out with every year. I think Medicare in America does the same thing, but this is just the same, we're just talking about essentially that process, but on the provider to the private insurance level where, we have to have industry parity between these things just so it's, well, frankly, just so it's a lot simpler.
This is like there's all payer rate setting, like setting the same rate for all payers. And, most countries do central negotiation. My proposal is even more modest because I'm saying, well, just make sure every provider is setting the same rate. In the long run, I imagine here's what insurance companies are going to do. They're going to say, okay, here's how much we're going to pay for each one of these services. And it's going to be based on how much they think they cost. And the providers are largely going to just abide by what the insurers say. And, if the insurers messed up, well, they're going to say, well, we're not going to pay that price. And there's they're going to come to the table eventually. The one thing that this system allows is that if you have a physician or a hospital, which is just way better at providing a specific kind of service, they can charge more, and you can allow certain insurers as like a extra benefit to provide access to those providers by paying those higher prices. So it's not like standardizing everybody at one reimbursement rate and like one level of care, which I think is, why not? That seems good. That's it. That's it for that section. Wow.
There you go. I think what you'll find, guys, obviously, like we said, is that if you, we're not health economists, right? But if you had a room of 20 health economists from all over the world who are truly like got their doctorate degree, studied healthcare economics for their career, you'd probably find like a really large amount of agreement, like 80% overlap in terms of what they would recommend for the American healthcare system. And obviously people who are just kind of wonky people that look into this themselves, there's typically going to be a large overlap as well. Like, which healthcare system is better? Is it the Japanese model? Is it the Swiss model? And it's like all these systems have huge overlap. And we can talk about some of those differences here. But fundamentally with the American system, I think if you had to put it into simple terms, is that supply constraints are like pretty crazy in a lot of aspects in the American system. And there's also way too much decentralization, not only in the private market, but also in terms of public offerings with Medicaid, Medicare, CHIP, the VA, Obamacare markets, shit like this. It's way too idiosyncratic. It's also the fact that we have 50 different state level regulations depending on the program. Like,
there's so much fragmentation.
I mean, if you threw a dart onto a board of the United States and hit a random state, it's a totally different world depending on where you live. Like, somebody mentions Romney Care in Massachusetts, where they have essentially like a more properly set up Obamacare. In Massachusetts, they have extremely low uninsured rates, right? And healthcare inflation in Massachusetts is typically lower. Right, and oftentimes, well, let's say it's much lower after the reforms, right? They still have more expensive healthcare, but again, they control costs better because of their system. The state of Washington has like state negotiated insurance premiums, almost a little bit similar to what Mike is saying. Some states have that. Texas is like the wild fucking West, and there's a shitload of people uninsured here. I think it's like the highest uninsured state in the country by percentage and in terms of absolute people uninsured.
You get like really crazy things like the coverage gap. So like because we didn't expand Medicaid in Texas, you have these people which are too high income to qualify for Medicaid, but they're too low income to qualify for subsidies to buy insurance themselves. So like for these people, if you just reduce your income by a few dollars, you can actually go from having no insurance to government paid for insurance. And like, that's insane. Like conservatives want to talk about how, the welfare state reduces labor market participation, makes people not work. You know what does? These huge cliffs. That's what does. You know what? I want more people to work. That's why I want to expand Medicaid and increase welfare.
Okay. Well, the
next section.
The next section. You've got it already lined out. Let's go for it then, Mike. I thought.
Okay.
I've got it too. But.
Achieving universality and affordability. So this one's pretty short. It's really easy. We tried to reach universality previously with an individual mandate. That's what they do in Switzerland. Say, hey, if you don't buy insurance, we're gonna fine you. But according what we actually said in the Supreme Court, it's actually a tax. It's not a fine. We're gonna tax you. You better do it, right? And like, what happens? Well, a lot of people are like, crap, I don't know how to enroll, or like, screw you, big government, I don't want to do this, right? And like, that's unacceptable. Everybody needs to be enrolled. Individual mandate's not really that popular. So here's a different idea: automatically enroll people. So a lot of the people who don't have insurance right now are poor. So if we automatically enrolled them in like, Medicare, which now has all the Medicaid money, their coverage is going to be like really low premium, if not free. For the people that are higher income that don't enroll in health insurance, yeah, we're going to charge them. We can charge them, a monthly bill. If they don't pay it, we'll charge them on their taxes. Because ultimately, if these guys go to a hospital and they refuse to pay the bill, we already socialized that cost. So you need to pay into the system that you are going to benefit from. The second thing is subsidies. So, Econoboy, explain your take on how we should do these subsidies, and then I can talk a little bit more about it.
Subsidies on people's individual insurance, basically.
Yeah, their insurance plans. Yeah.
Yeah, I mean, it's hard to say. Like, I think in the long term, a single payer system is probably best. I mean, I think that Micah makes a convincing case for some sort of private option. But the reality is, like, in my ideal system, it's like we're talking about, are 75% of people on government plans, or basically 100%, right? Like, we're talking definitely on the margins here. I would say in terms of cost sharing, I mean, even in a single payer system, you should have probably some cost sharing, because one thing that characterizes literally all forms of insurance, right? If you're a government or a private entity that offers insurance, and every country falls in this spectrum, even if you're the NHS, right? The NHS is covering care. They're just providing insurance from the supply side and also the demand side, essentially, right? But when we're talking about that, you have to have a way of getting rid of this fundamental failure in healthcare called moral hazard. For people that don't know, moral hazard's this idea that you're insulated from the risks that you're taking. And that's bad because it creates market distortions. Now, how does this apply to healthcare? Well, it applies to healthcare because you genuinely do have a problem with unfettered access to healthcare, that people they consume way too much healthcare. They'll go to checkups way too often. They'll order way too many tests. A lot of people become like, essentially like, why the fuck not hypochondriacs, just ordering a bunch of different tests and procedures and this and that, which really, really burdens the healthcare system in terms of costs. And especially if you're talking about a public system where that cost is socialized, arguably the moral hazard could be even worse, right? So you have to have, exactly. So you have to have some level
of cost sharing.
You have to have some cost sharing, yeah. So I would say what that number is, it's hard to say, like if it's, to 10% of your costs, 20% of your costs. Some countries just do lists, right? It's just like, well, the way that we control moral hazard is you just can't access healthcare until we say you can, right? And
they ration, right?
Yeah, and and to be fair, like you've read the literature on this. It's not clear to me which system is like necessarily better, especially from a moral perspective. Like, let's say that, I don't know, let's say that your back's been hurting and you're like, fuck, I need to go to the doctor. My back's been hurting. And you talk to your GP and your GP says, well, we can connect you with a specialist. Like, how bad does it hurt? And you're like, well, it's like a 3 out of 10. Like, I can still work. It's just like kind of an annoying, aching pain. And then the doctor says, okay, well, and then these are your two systems. One system is the doctor says, well, based on how severe it is, we can get you to see a specialist in 7 months. And then 7 months later, you see a specialist, get it taken care of. But then another system is, well, based on your insurance and this and that, like, we can expedite this process, but it's going to be a $500 copay, and then you're going to have to pay 20% of the healthcare costs, whatever the specialist ends up coming, and you can see your specialist in 1 month. Like, which system is really better for the patient and for regular people?
I think that, you probably need to do a little bit of both. Like, it just really depends on, what you're doing. I'm a big, gold tier insurance. I think that's pretty good. Like, 80% of somebody's healthcare costs are going to be expected to be covered by the insurance. you're going to be on the hook for 20%. Primary care, preventive care will be free. Specialist care will have co-insurance or co-pays. Emergency care, hospital visits, like let's say like root canals, things that are produced by largely probably
Yep.
behavioral stuff. Like you want to have like maybe a deductible or something to say like, hey, like go get the preventative care.
And
hey, don't wait till
just
the
to be
last
clear, like,
minute.
something that's worth mentioning is that if you enact all the supply side reforms that we're talking about, both in terms of cost negotiation and in terms of just like literal supply of healthcare and healthcare providers, that the idea of like, oh, I have to pay for, like right now, it's like if you told me, oh, I have to pay for 20% of my fucking brain cancer treatments, it's like, holy shit, like what is that, $100,000? But in our system, ideally, that 20% would be substantially less than it is now because costs would be much better controlled in our system, right?
Oh yeah, there's a lot of ways you bring, and like, we're not asking for a crazy amount of cost control, right? Like this is dramatically better coverage than most people. Now, what I was wondering about originally is there's basically two different ways people organize these subsidies in countries. One way is you do universal subsidies, and that's single payer systems. The government taxes everybody, and there's no premium, right? And you could have a private insurance system still that's funded by taxes. Basically, the government says, okay, here's your money. Spend on private insurance. Go buy a private insurance plan that's equal to this, and if it's more expensive, you pay the rest. The other way, which is the way that's most frequent in Bismarck systems, is the government basically says, hey, poor people, hey, poor middle class people, we are going to subsidize your premiums. You're going to pay 7%. We'll pay the difference towards a standard plan. If you want to get a nicer plan, well, you're going to pay the difference between the standard plan's cost and the more expensive plan's cost, but you're still going to pay 7%. It's a little bit complicated, but it's really not that. All the math is automatically done whenever you're shopping for insurance. And so it's means testing versus universality. Now, I'm universality pilled. I think means testing is just an inefficient form of taxation. I think having paying 7% of your income towards your premiums is basically just taxing people 7% of their income up to a certain cap, which is the amount that those premiums are. Which means it's a 7% tax on your first $80,000, which means people over $80,000 are not exposed to that tax. And like, who would ever propose a tax that only applies to people under, an income below this amount? Nobody would really do that. So,
yeah, I mean, if we're talking about just like essentially just whether or not we should have premiums or not, I mean, my ideal system would probably say, no, like we're gonna have no premiums because like you said, like I'm not sure if in the literature there's like a behavioral difference between basically paying a VAT for like a universal premiumless system versus paying some combination of other taxes plus having a small premium that you have to pay. Maybe there is a behavioral difference. But
so here's what I've gleaned. This is the best argument for keeping premiums around is that people are much more likely to support austerity when it comes to funding their healthcare system if it's coming from taxes than austerity if it's coming from their own premiums. Private insurers have more ability to raise your premiums than like maybe the government would. Now we can get to my proposal later, which I think that this is able to do the tax.
Right, because what you're saying is that if somebody advocating cutting subsidies where you pay a small premium, then people would in a real sense, see that premium increase because that would shift the subsidy to the premium where people would have to make up that difference out of pocket, right?
Yeah. Well, it's like, these systems, it's easier for a private insurers to hike your premiums than it is for the government to hike your taxes. And because of the subsidy, it moves with the premiums. The poor people always are going to be able to afford it. And the idea is, well, if you have healthcare spending grow faster in these countries, they have greater access. And that's just true. In Germany, in Switzerland, the wait times are the lowest. The number of physicians per capita is some of the highest. Like across many benchmarks, they perform better. And it's largely because they just spend more. When you spend more, I mean, more people become doctors, right? You get more access to care.
And again,
in countries in countries where all the money is coming from the government, like the UK, you're probably going to have lower quality coverage or lower quality providers, right? Because everything has to be free, but the bucket of money is fixed, which means, new service, we're not really going to cover that. New procedure, we're not really going to cover that, for as many people, which that's a trade-off.
Yeah, and just to be clear, like these insurance premiums are really not very large. Like I just looked up here, the average basic Dutch health insurance premium, they're like kind of a Swiss model where they have essentially private insurance with these like public subsidies for lower income people. The premium for the basic Dutch healthcare system on average, this is 2021, is only 120 euros, which is, call it $150 a month in America. And like I have, my private employer health insurance plan, which is a high deductible plan, is $200 a month, right? So
that's actually unbelievable. Like I think that's really cool.
well, these premiums in like managed competition systems, if there is a premium, obviously that people are paying, it's really typically not that much, right? And so, like, if you can look at the premiums for Medicare, a lot of people assume Medicare is free. The reality is Medicare is just like really low premium, like good insurance. It's like if the government just offered like a pretty good insurance plan at a subsidized rate. And that's kind of what we're talking about for the economy at large. And so, to me, like the idea that if there's like significant behavioral differences, which is kind of what you're describing in terms of maybe the sustainability of the program between having zero premium and having a premium of $150 a month, and then lower income people pay zero. Well, yeah, then just charge the premium. Again, you shouldn't like whatever system works best, obviously, right? And I mean, these premiums are just like I'll boldly say pretty much everyone in the country of America would probably rather pay $150 a month than have to deal with all the 100 different layers of bullshit with our healthcare system, especially because that $150 a month is probably cheaper, equal to what they're paying already for their private insurance.
Yeah, so like in Switzerland, they pay 359.5 francs per year, which is
it's almost 1-to-1. Yeah,
ours is worth ours is 1.17 to 1. So we're gonna have to add another 17% to that.
So maybe about $400 a month or something.
Yeah, $400. I mean, that's not that bad, especially if you're on low income. If we did a subsidy program, we capped at 7% of income. That means like anybody over like $90,000, below $90,000 is getting government subsidies. So like that's vast majority of people are going to be totally fine. Now, yeah, I think it's mostly pragmatic. My ideal system is the government tax finances a basic allotment, and so that basic allotment is equal to what the premiums would be for the public Medicare. Everybody's auto enrolling in that. There's no premiums. It's free. And if you want to leave and take those subsidies with you, you can buy private insurance. So if the public system doesn't get adequately funded, like the system in the UK or the system in Canada, well, people will say, crap, well, I'm going to go get private insurance, which is I'm going to pay a little bit more. And people will be leaving the public system. And now I think there'll be a stronger impetus to increase the funding of the public system. And there's like an escape mechanism if like conservatives start really, being super austere with the system, right? Because you don't have that escape mechanism.
I mean, just to be clear, like I think Micah, SDL, and I think we all agree that in terms of a transition system, it's probably never the case that you're going to go from the American system to banning private insurance. Right, like you probably need some step in between because most people in America are just simply not on board with the idea of no basic private insurance. Right, like you need that. I mean, like if you want it to pass.
It's kind of un-American to have like zero options, like zero choice, just the government. And like people will say let's lower the Medicare eligibility age. I just don't think that's very plausible. I like the idea. I mean, I would lower the Medicare eligibility age to 0. And now we have everybody on Medicare and Medicare Advantage. That would be awesome. That'd be like an incredibly large improvement. Here's the thing. That means everybody else loses their insurance. And you're going to have to raise taxes a bunch, which is just not going to be cool with people. And so what I think you do is you say, hey, if you're on the individual marketplace, we're going to cap your premiums at like 8% of your income or 7%. Bam. Just like that, a bunch of people start coming to the marketplace because it's so cheap now. You tell employers they no longer have to provide insurance to their employees because we force them to. And we in their subsidies, we subsidize them significantly for doing so. Now all these employers are like, well, crap, it doesn't make sense to pay for this anymore. People go to the individual marketplace, and there's a really good public option there that we're auto enrolling tons of people into, including poor people.
Yeah, and there would still need to be a lengthy transition time. Like any country that transitions to, I mean, even Obamacare took what was it like? They had the stepladder enrollment where the penalty would go up every year, and the mandate kicked in 2012, which was 2 years after. Like, so when it comes to this, like, probably what you would do is you would start out with some Medicare reform, and then you would expand eligibility, and then the regulations would come on over the course of 4 or 5 years or something like that. And then eventually, like Mike is saying, like, you would eventually achieve universal coverage, probably with a significantly better, governing system for healthcare costs. And, it's one of those things where also people would have to be somewhat patient, right? Like, Obamacare was better than what we had before, right? But people literally hated it for like fucking almost a decade after it was passed. And it's only until recently when Obamacare's sort of approval ratings have ticked up into the positive, because it was, a relatively big change from what we had before, and it did shake up the market a lot. And these things would do the same thing, right? South Korea, when South Korea transitioned to their universal healthcare system, took them a decade to do so, right? Just logistically, these things kind of take a while, and so that's something that
There's basically two paths, right? There's either Obamacare 2.0, where you take these individual state-based marketplaces and you try to build them out, and you add a public option, and you basically slowly move everything to the state level. You take Medicare Advantage and you bring those people back into the exchanges. I have a whole plan about how you can do this. You take Medicare and you make it a state-based thing. Now it's still federally managed, but it's just there's risk pools on the state level. Or you just try to increase Medicare eligibility. I think that's harder. I think there's less ability for us to do that, but like that would be completely awesome. And these are really the only two options.
Right.
And even if you want single payer and you say, Mike, screw private insurance, no choice for anybody, you should still agree with either of these mechanisms, because these absolutely get you closer to what your ideal system is anyway.
Okay. Yeah, I mean, at the end of the day, like, we live in a democracy, right? And so if even if you were able to, like, LBJ style, like, hard nose pass through a single payer system that abolished Medicaid, Medicare as we know it, abolished the VA, got rid of all these private insurance plans, and let's just say, like, genuinely speaking, like, the single payer system on paper, like, offered better insurance, like, the transition cost alone would turn a lot of people off. It would be such a big change in people's lives that a lot of people would reactionarily be against it. It's not to mention that it kind of depends on who passes it, right? Like, the more radical plan that, like, the Democrats passed in this regard, you're going to have a lot of stupid conservatives that are just like, man, fuck this, because goddamn Biden cares bullshit, and I used to like my shitty rural healthcare fucking system that I have. And it's like, that's not good that people react that way, obviously, but it's just kind of a fact of the matter that you would probably need to have a more, like, I say more modest. Like, the reality is what Micah and I are proposing would ensure, like, tens of millions of extra people, and 100% of people would have much cheaper healthcare insurance in a much better governing system.
You'd have universal healthcare and universal affordable high quality healthcare. Yeah.
And it's not like, it's not like, oh, just a stupid little incremental reform. The point is, it's not full, like, healthcare decommodification or whatever, like some people propose. But the reality is that there are political constraints. You're not a dictator. You can't just pass whatever you want. Obviously, you can advocate for whatever your ideal system is. But at the end of the day, like, if I'm Bernie Sanders, and to be fair, I think Bernie Sanders would recognize this. Like, he supported the ACA when it was proposed, right? If you're Bernie Sanders and you're the president now, and you're negotiating, like, a healthcare plan, you've got moderate Democrats that are, have these problems with this healthcare system and they can't get it passed, but hey, we'll pass a public option. Well, obviously, you would just take that, right?
And also, like, I think some of these people, that, like, their ideal healthcare system is just like a little bit extreme. Like, Bernie's single payer proposal is way more radical than any single payer system in the world. Free healthcare in complete coverage for absolutely everything. Like, right. Hearing, in-home care,
no co-pays, no deductibles, yeah.
And he wants to keep current reimbursement rates, but like the utilization effect of that would be like, you'd have incredible shortages for doctors because we don't have the supply, we don't have the bottlenecks haven't been resolved, and the cost on that would be just really ridiculous. So
yeah, it would just be a plan that would be hard to stomach from the average person's perspective, right? So it's just important that it's important that you want to be, somewhat flexible on what you're proposing, just because there's a political constraint to everything that we're talking about here.
There is a good debate to be had, and I have this internal debate all the time about whether we expand Medicare eligibility, and that includes Medicare Advantage, or we do Obamacare 2.0. And we can have this debate. What we should not have the debate about is whether it is realistic for us to do Medicare for all tomorrow. And like, oh, like why didn't Biden just like hold the vote and we just took everybody's insurance?
Even Bernie's plan, which was like nominally a Medicare expansion, was we're going to expand Medicare itself, right? So like we're going to cover all that extra shit and we're going to get rid of the premiums and deductibles and all that stuff, right?
Yeah.
So we're going to do that for people plus 65. And then I think his plan was to lower the eligibility age of that expanded Medicare plan, I want to say by 20 years each year of his presidency. So eventually it goes 65, then 45, then 20, and then by the end of his presidency, it gets to, everyone's covered by Medicare. And even that is transitionary, right? And everyone should recognize that when we're talking about something like this, like it just takes a long time. You know, look at the history of any healthcare system in the world that's much better than America's. The history is going to be something like the doctors were against it because the AMA in every country is terrible in this regard. The government passed it anyway, and then it took several years to actually fully implement, you know, the NHS, the Canadian Medicare system, all these systems. You know, it's a sort of a fine-tuning process until you get to some stable state where you have universal coverage, you have relative affordability and depressed costs of healthcare, and then all the debates are kind of on the margin, right? In the UK, it's like, how much are we funding our NHS? How much private options do we have? Similar debate in Canada. In the Netherlands, it's like, how much should premiums go up each year because we're negotiating that every year? And how do we handle risk pools and, you know, the changing needs of our population? So
in some countries, switch from like single payer to Bismarck. You know, in Portugal, they have a Beveridge model, National Health Service, and there's a big push to push it towards more of a Bismarck model. That's what one of their main parties is all about. And like, there's benefits and like trade-offs, but you just need to get to one from current dysfunction. Okay. Section C, improving quality. It's really easy. We're going to increase the supply of doctors. That improves quality. We're going to increase the supply of providers by ending certificate of need loss. That improves quality. It expands our number of hospital beds, which are sorely lacking. I think that we should do full expensing for medical capital expenditures. So if you are a private firm that operates a hospital, you currently actually pay a tax on the investments that you put into building new facilities or improving your current facilities. There's no reason we should tax investment. When you tax investment, you get less of it, right? And also, there's a tax on medical research because you can't fully deduct it. You got to deduct it over time. We shouldn't be taxing medical research. That doesn't.
Yeah. So for people listening, what Micah's saying there is essentially when you do a capital investment in this country, and to be fair, I don't know if any country has full expensing, but it's not that it's a bad idea.
Estonia does. Some countries do.
Man, Estonia, just the most wonky tax system possible. But anyway, that's a story for another day. The point is, what Mike is talking about, to explain it simply, like when you invest in certain things as a company, like say that you're a company and you spend a bunch of money to like build a factory, right? That's a capital investment. Factory is capital, made up of capital. Let's say it costs $100 million, right? So you spent $100 million to build this factory. On year one, you can't just say my revenue minus my 100 million, that's my profit, right? The government doesn't let you do that, right? What the government forces you to do is take that factory and say, well, what's the shelf life of this factory? Let's say that it's 10 years. This factory is going to last 10 years until we have to completely rebuild it. And the government says, okay, you can deduct 10 million. You can deduct 10% because it's a 10-year life. You can deduct 10% of this project's life from your taxes every single year, even though you spent 100 million to build it, obviously, but your tax benefit is delayed by 10 years before you can get that full benefit because the government just doesn't allow you to deduct in that way. The argument that like accountants will make is that this is necessary because a factory is in and of itself a revenue generating asset, right? And so if you allowed full expensing immediately, this would be bad because the factory generates revenue in other periods. So you should adjust revenue and tax benefits by the periodization of that revenue and that life of that asset. What Mike is saying is, yeah, but medical expenditures and medical investment, that's just like a social good. So we might as well just give you all the tax benefits immediately because we want to encourage that kind of investment.
Well, I think that if you don't do full expensing, that's distortionary. And I think everything should be fully expensed.
No, I know, but I'm just saying on the medical expenses especially, like there's even less of an argument. And to be fair, like accelerated depreciation is a thing. Like these depreciation schedules are subjective, right? They're set by the IRS, right? So in that effect, they're almost certainly distortionary because shelf life isn't always what lines up with the IRS sheet anyway. And when it comes to medical expenses specifically, again, there's just like that social purpose. Like, well, we want to encourage this specifically. The government does this with other sorts of assets that have accelerated depreciation schedules or certain expensing that is allowed versus not allowed. And there's a lot of nuance here. The government already does this. Micah's just saying, we should probably do this with like medical research investment and medical investment in general.
Yeah, and like this stuff actually, it matters. It's wonky, but it matters. It makes an impact on supply, and more supply, or better. Also,
well, yeah, just to be clear, like to put it in a monetary value, if your effective tax rate is 20% and you spend $100 million on that factory, let's say you spend $100 million on building a hospital, right? Well, that means that the value of that tax shield is 20% times 100 million. So that's $20 million. And there's a big difference between basically getting $20 million today in the form of full expensing versus $20 million split over 15 years, right? There's a big difference in circulation of money, how you can multiply that investment and recirculate that investment when you allow companies to immediately get that tax benefit today.
This is a fantastic explanation. Good job, Econoboy. Okay. This is something that we absolutely all agree on. Throw public money at innovation, medical innovation, okay? Subsidize medical R&D, do government medical R&D, like fund the National Institutes of Science. Maybe consider doing innovation prizes, basically saying, hey, if you can make a drug that has these specifications and these improvements over current drugs, we've estimated that the social benefit of that's going to be $60 billion. We will pay you $60 billion or $50 billion. And now, if you create that innovation, instead of having intellectual property protections where you basically have a monopoly on it for 20 years, you get paid that money, that innovation goes out, tons of different drug companies can produce it or whatever it is. And the price is like a market price, a much lower price. And you accelerate innovation and you lower prices in the long run.
There you go.
So that's good. There's also wonky ideas like Harburger taxes. We don't really have time to talk about that. I think that we should regulate pharmaceutical ads. Some people think we should ban them. To me, I've read a little bit of the research on this. It doesn't really seem like all pharma ads are bad. Like it increases drug use. It's not clear that actually this is a net negative effect because sometimes people actually need these drugs. But we should force them to have regulations on them that force them to be more honest, like maybe quantifying benefit claims and mentioning quantities that relate to their harm claims as well, because that could give consumers a better idea of the real impact this medication has.
Right.
Okay. Last section. Ending job lock. Job lock sucks. We already mentioned this. The way you end it is you end employer provided insurance. How do you end that? You end the employer mandate. Stop forcing employers to give people insurance. That's step one. Step two, stop subsidizing insurers incredible amounts for buying insurance for their employees. We spend about $250 to $300 billion every single year on that. We could get universal coverage for less than $150 billion. So just by ending that, we can pay for a lot of these other things.
And to be fair, to be clear, in a lot of these systems that have universal coverage, they have employer-provided insurance, but the way that they avoid job lock is that if you leave your employer, you're automatically covered by whatever the public insurance option is. Like, hey, if you get sick between jobs, we're just going to kind of assume that you're on the public system when we charge you for your care, right? So
they do that in like Japan. I mean, most countries are not really that way. Like most people are allowed to choose their own plan and the plan moves with them. And that's preferable because like, let's say there's public insurance that you go to, like you still might lose the current doctor that you're seeing. Right? Or
no, I agree. It's preferable to get rid of employer-based insurance, but again, just to the people who, for some reason, are so scared that they won't be able to have their employer-provided plan anymore. It's like, look, at the end of the day, you could just make people automatically enrolled into like a default public health insurance system, which is like pretty flexibly able to be integrated to any proposal that you have. Like it's pretty crazy that in our system, it's just crazy that we don't have that. Basically, like the idea that you could. Let's say that you have a 6-month non-compete clause, but you get hired to start at a job in, month 7 of that non-compete clause when it expires. Well, your employer insurance is typically only going to be, 1 month of coverage after you lose your job. So you have to live a completely paranoid existence for 6 months because, oh my God, like what if I get in a car wreck and I fucking end up in the ICU and I don't have coverage? Like, it's just kind of crazy that we don't. And a lot of people will do, like wealthier people will buy like coverage insurance for that gap, but actual private market insurance in America, if you're buying it outside the context of an employer or being poor enough to afford or being poor enough to be able to get Medicaid or something like that, is super expensive. $1,500, $2,000 a month. It's
you
ridiculous.
need to like get a lawyer to read it with you because there's like they can have a benefit cap, so you get hit by a car and they help you. You pay your deductible off. You're like $15,000 in debt now. Then they pay for part of it and they say, this is too expensive. You're done now. You got to pay for whatever the rest is. I mean, these plans are just garbage.
Not to mention self-employed people get completely fucked in our system where they have to get that private insurance. And again, like individuals buying private insurance in this country, it is ridiculously
unless
expensive.
you get a marketplace plan, and a lot of people get subsidies on the state-based marketplaces. And so it depends on where you are, but those are fine. Good. That's where all the increases in enrollment are coming from. We just hit record enrollment in insurance is because more people are coming in and taking advantage of the system Obamacare set up. Okay. So, other things you could do is, you can subsidize the marketplaces more. The more that the subsidies are on the individual marketplace, the more people that would have gotten group insurance will find that it's preferable to get individual insurance. And then eventually we can basically prohibit group insurance and require all new insurance enrollments to happen on the regulated state marketplaces. So we can, and we can allow providers to provide supplementary insurance, but for your primary insurance, that will be something that's individual and moves with you, which will completely end job lock.
Obviously, job lock is a big problem. Again, it distorts another market, right? I mean, it distorts it in more than just on the employer side. Like one thing that kind of sucks is that, unions, right? Like unions have to negotiate on health benefits a lot as well. And it's probably just better to simplify those negotiations as much as possible, like both for the employers and the unions, right? Because why would you want to add like an unnecessary thing to your employer negotiations? Now, in a lot of these countries that have more universal coverage, again, all these countries have private options for insurance on some level, right? Like, a more government-dominated system like, Norway or something, for instance, they have private supplemental insurance. That's something unions often negotiate on. But again, the scope of that is much more, essentially like much more narrow than trying to negotiate for an actual sort of primary care plan, both in terms of cost and in terms of complexity.
And the job lock effect is like, oh no, I'm going to lose my optical insurance. No, like,
right.
I like it's
every 2 years really I get a new pair of glasses. Yeah, it's just really not as big a deal. And so, yeah. Anyway, all right. What's the next thing, Micah?
So this is now we're in section 5, addressing problems in the American health system. Policies we don't agree on. So this is policies I didn't agree on with SDL. There's basically like 4 different areas. Now we actually already covered some of these, but okay. So I've explained my model multiple times. People have public insurance, 0 premiums. You could switch it out for private insurance that's either 0 premiums or heavily subsidized if it costs more. Do you think that this is a good model? If no, what's your alternative?
Yeah, I mean, obviously, I think it's 1,000 times better than what we have today, right? So if I was in Congress, and I had to vote on this plan, I'd enthusiastically vote in favor of it. It would be one of the most transformative pieces of legislation that's been passed in like 25 years or something like that in this country. So, I mean, it's obviously would be a much better system than we have today. Again, it's just a matter of, in the long term, do we end up in a state where like we want to transition to like a full single payer model? And the reality is, I think like practically speaking, people just probably wouldn't want that. Like it seems like when multi-payer systems get implemented, they tend to work very well. And like insofar as they work very well, people tend to like not really want to rock the boat super hard by like banning private insurance or anything like that. And So I mean, I'd be perfectly okay with that, right?
Yeah,
There's nothing
it's like,
wrong.
in my
Yeah.
view, it's like, okay, I think that public insurance, it will have tons of money behind it. The government, I think, it has a very good incentive to do things correctly. There's so many people that are passionate about it that are probably going to be working at CMS. And so it's going to be best in class insurance. It's going to have crazy scales. Tons of people are going to be automatically enrolled. And so for like a broad network, medium cost plan, the Medicare is going to be great. This new version of Medicare is going to be great. If people want more expensive care, they want to cover more things, more expensive procedures, private insurance will probably be better. For some people, they may want all that extra coverage, but they want it for the same cost, and they're going to be willing to take on managed care where their insurance kind of bosses them around more. Well, private insurance might be better, right? As long as it's a competitive market, like I don't doubt that there's going to be a certain percentage of people which benefit from having this choice. And like, it's not like there's huge administrative costs. Like me and you have talked about all these standardizations that would depress the administrative cost. And so to me, it seems like there's only benefits and pretty much no downsides. It increases, it kind of forces the public insurance to do a good job because everybody will leave the system if they don't.
But yeah, the only like strict benefit that you could argue, and this is, I mean, essentially the only argument that I typically speaking hear from people who advocate a single payer system, which I do. Like, I think that in a world where we've enacted your plan and we're like 10 years down the line, like I'm still probably in my head thinking, we could probably replicate this with like a more strict public option, but we'd also have lower administrative burden, right? But like you said, it's not like these multi-payer systems have crazily insane administrative burden like compared to Canada or the UK or something like that. Like one of the reasons why America has particularly bad administrative burden is because of the complexity and layers in our system. So like just getting rid of those layers and offering a more sort of basic regulatory landscape would get rid of a lot of the administrative bloat within our system, right?
And does like 40% of people being on a regulated private insurance system where all the payments and clearinghouses are centralized and 60% being on public insurance constitute way higher administrative costs? And even if it does, which it doesn't, those administrative costs are privatized. They're not pushed onto the public. Like people are willing to pay more, even in terms of administrative costs, to get this different plan. That seems totally fine. Like it seems like
it's just yeah. You would just have to be sure, because like we've talked about before how like sometimes people get scammed into taking like Medicare Advantage plans when their Medicare plan might be better, right? And so similarly in whatever this system is, like you have to regulate it to where there's like really radical price transparency and like a really clear understanding of this is how much this system costs. This is what it covers, right? Because you wouldn't want to be in a situation where of that 40%, like 10% are just like mistakenly choosing a worse, worse plan.
Well,
for various reasons, right?
that's true. That's true. I mean, I think the state level marketplaces do a better job. They're newer than Medicare Advantage. I think Medicare Advantage has like a risk adjustment issue and there's problems, but like these are not huge problems. There's like, oh, we just can't have anybody have private insurance. I'm averse to the idea of public monopolies. I think that people that are like scared of choice and like just say, oh, you need to have like absolute government domination over this. Like, I think that's just kind of a problematic mindset. But yeah, that's my proposal. Okay, so we pretty much agree on that. Now, here's another question: how should insurers pay providers? How should that be structured?
How should they pay them? Like mechanically, how should the insurance money get to the provider?
No. So like, what's the payment system? So I can give people a breakdown on this. So traditionally, insurance has provided providers a fee for every service. So, the service is a medical checkup. The insurer says, we're going to pay you $60 for this, Medicare. And so whenever you go to your primary care doctor, they get $60, right? And if you get a test, that's $35. And so the insurer pays $35. And the issue that people have raised with fee for service is that it doesn't really produce the best incentives, right? Because your doctor is ultimately telling you how much healthcare you need, and your doctor and your provider gets paid for the more healthcare that you use. And so it doesn't necessarily incentivize them to minimize cost or do what's best for you. They have an incentive to try to increase the amount of fees they charge you as high as possible. And so there's tons of different proposals about alternative ways you could pay for healthcare. One idea is a bundled payment. So you could, or like a capitated payment is what they call it. So it could be, you know, you go to the hospital and you're admitted and you're diagnosed with having some sort of illness, right? Like your leg's broken and there's a treatment that's required. Well, there could be a flat, basically, reimbursement they get for that condition, instead of like paying for each one of the lacerations and paying for the bandages and paying for, you know, this specific part and this specific part, which may incentivize providers to minimize cost. Another way that you could do capitated payment is you could tell people's primary care doctors that they're going to get, say, $80 a month from the insurance. And for those $80 a month, they have to provide unlimited primary care services or close to unlimited primary care services to the individual. So like there is no incentive to make them stay longer or bring them in extra. And it could say they don't have to worry about this whole billing process. And now they could just focus on meeting the healthcare needs of their enrolled patients, stuff like that.
Yeah, I mean, that makes sense. I mean, I think, to be fair, I'm not sure in terms of, because you're kind of describing almost like fraudulent billing, because that's not legal what you're describing. You know, you can't just like run a patient's bill up with procedures that aren't, you know, required. And then get the Medicare money, right? Because, you know, you technically provided that service to a Medicare patient. You know, people go to jail for that. So I'm not really sure, like, as a percentage of expenditure,
it actually does. It does matter. That people,
not that it doesn't matter.
There's a lot of health econ people which will fight you over this, but they're like, Americans consume tons of tests. Americans consume like very high intensities of care, and it's not like illegal. You know, like. Maybe their provider just thinks, oh, there's a risk, right? And they have a financial incentive to say, oh, you know, if there's a risk, might as well do the test, right? Stuff like that. I don't think it's a huge deal. For me, this is my proposal. This is the radical proposal. Okay. I think certain types of services are very shoppable or could be very shoppable if you had price transparency. I think a lot of surgeries, things like knee replacements are very shoppable. Drugs and medical products are extremely shoppable. And so for these shoppable services, instead of the government basically saying, you know, we're going to negotiate with all the providers and we're going to say which things you can have and which things you can't, the government will say, okay, we will pay 90% or so of the cost up to this amount for XY treatment. So like for me, I'm diabetic. I'll get basically an insulin budget. We will pay 90% of your insulin costs up to, let's say, $300 a month. You know, that's like maybe adequate to pay for basic insulin. If you want to go if you could find a cheaper insulin, well, you save some money, right? Because you say the 10% you would have paid extra on whatever the difference was. If you want to buy a more expensive insulin, we're not going to say no, right? You take that money and they're going to pay 90% up to $300 off my more expensive insulin, and I can pay the difference. So it expands people's choices amongst different treatments and providers. It creates a genuine market mechanism to push down costs because people see a saving whenever they shop around. And many people say that is why Singapore is one of the most cost-effective healthcare systems in the world, because they have genuine price competition for shoppable services.
Yeah, I mean, I don't know who would have a huge problem with that. Again, like at the end of the day, you can only cater to the extreme so much, right? You know, like people who think that, you know, all healthcare should just be free and that's just how it should be. And it's like, well, literally nowhere on the planet has ever implemented a system like that, right? Like
everybody
that just doesn't.
The highest tier care, everybody.
Right. Like, and it's just like the issue is that there's just like, I think a lot of people think that overconsumption of healthcare just isn't a real thing. A lot of people think that, you know, insurance companies provide quite literally no value other than to the capitalist investors who own the insurance companies. And it's like, well, no, like there's probably some administrative efficiency and like things that we can do. I mean, after all, like I was reading, I don't remember if I mentioned it last episode, but like I was reading an article from the People's Policy Project. And, you know, one thing that was very interesting that they talked about was the Finnish, they called the Walmart of Finland, which was this cooperatively owned chain of grocery stores, which owns like, I think like 50% of the market of, and this is the most compelling to me, the argument for a multi-payer system is the idea that in this Finnish system, the cooperative Walmart, example, they said, well, how do you feel about having to compete? You know, wouldn't it be better if basically all grocery stores were kind of, you know, cooperatively owned under this umbrella? Because there seems to be so many benefits to your mode of organization. And the CEO, who's like this democratically elected CEO of this cooperative system in Finland that owns 50% of the grocery market, they said, well, no, actually, we benefit from the fact that there's private alternatives because we can look at their models and we can see what they're doing that is better than what we are doing, and we can implement it. Just like a basic, like, oh yeah, creative destruction is probably a good thing, and like, look, you know, being able to experiment in decentralized fashion of different models of insurance and models of care is probably a good thing, right? And so, yeah, in that regard, you know, setting up transparent markets for things like you're describing probably makes sense. You know, just having some basic price transparency and,
I mean,
you know,
I think it could have a substantial impact
no frills
on,
billing, right?
you know, it could have a substantial impact on people's on the prices that people end up paying, because then you have market pricing instead of like our chaotic insurers pay whatever like crazy amounts pricing. It puts downward pressure on prices. Like, so that means that there's more of an incentive for certain companies to invent new technologies which reduce costs. Because, you know, that's going to give providers a real competitive advantage in market share if they incorporate them.
Yeah.
It's going to increase the commercialization of existing technologies, because that's a big problem in America. There's a lot of proposals that say, here's how we save money. We just incorporate all these technologies that already exist that people aren't using, because there's no feet to the fire of our providers to give us good prices, or we'll go somewhere else. Right. That's another point for private insurance. This kind of I call it internal reference price based reimbursement model of payment is used in Sidecar Healthcare, a health insurance company. I recommend y'all go buy a plan for them and promote it. And like, you know, if enough private companies started doing this and like it was saving people crazy amounts of money, then that would actually encourage the government to start incorporating it. So that's another case for multi-payer.
Yep.
Let's see. Is there anything else? We agree on cost sharing pretty much. Okay. Do we do price controls for drugs?
Price controls for drugs specifically? I mean, that's a good question. I think that I would say that when we talk about price controls, like you include government negotiation that as well. And I would say that if we're including government negotiation in the realm of price controls, I would say generally speaking, yeah, like there probably should be some price controls for drugs. And I mean, you're talking about price controls for medical services anyway, right? So I mean, drugs probably is a domain where that makes sense as well. So
see, I think this is probably one of the worst things we could do.
you think so?
Well, I think that, you know, we probably have to, this is why I think we should use this reference price based reimbursement model, because you have market pricing for drugs and for shoppable services. You might need government negotiation for unshoppables, right? But for shoppable services, you know, have a market-based price. Let me just send you
the issue though is like, here's a question. Making any drug is like necessarily a very capital intensive process, because you can't just have like Joe Blow's fucking, you know, factory making, you know, pills and shit. Like it has to be a very precise sort of capital intensive process. And so given that, like it's probably almost always the case that there's not going to be huge competition in a lot of drug manufacturing. Like for instance, the the patent on insulin medication, you know, that's been an open patent for quite a long time, but there's still not a lot of competition between.
There's a reason why, though. The reason why people don't use, like, they don't create the older forms of insulin that have expired patents is because they're much worse. They're much worse. Like I'm
not saying there's not, again, so I'm not taking it to be the case that we should like we shouldn't do like crazy broad price controls like people, you know, advocate for.
Take this out. The reason, so this is one of the reasons why I cannot be pro price controls for drugs.
That's Micah's TRT right there.
So I just sent you a screenshot in the chat. Hopefully we can put that up for the stream about a meta-analysis on the effects of drug price controls. I read a bunch of studies on the effects of price controls on drugs and their effect on R&D spending, expected future mortality, number of new drugs approved. It is extremely dramatic. Because if you're a company, you know, the average cost of creating a new successful drug is somewhere between 500 million and 2.5 billion dollars, and it takes 10 to 14 years. Most drugs fail, right? So this is the average cost that you have to spend in the average amount of time before you get a win, right? That is ridiculous. So you need to make
Well, no, but we're talking
margins.
about in this ideal world, right? So like I agree with what you're saying, right? That there's not, it's not like these prices just sort of come out of the blue. But at the same time, like let's say that we had our ideal system, right, where we allow immediate expensing of research expenditure, we have a lot more subsidies for research expenditure, this and that. It's like, dude, if you come up with a drug that like cures cancer, we probably shouldn't just let them charge like $20 million a fucking pill or something.
Okay, yeah. If we're subsidizing like people's R&D spending like 60%, then yeah, we could do.
That's what we recommended, right? Like there should be a lot more government.
Well, if we're doing our ideal, we're going to do like a Harburger type. I'm going to do some crazy stuff with IP. I was just talking about in our current system, like if we just start doing price controls like the rest of the world, here's what's going to happen. You're going to have a dramatic reduction in the amount of medical innovation, specifically when it comes to drugs and medical products.
Yep.
And that will kill people over the next couple of decades in America and in the rest of the world. And people will be worse off, mostly people with chronic conditions.
Yeah, I think that I think that the areas in which like true like rents are being extracted because of IP protections and things like this in medical devices and services and drugs, that I would agree that like that's more, if we're talking about the best policy, like that's more of a conversation for reforming IP and reforming perhaps how we produce those medicines and how we subsidize the production of those medicines than it is like strict price controls. However, I will say that it seems like every other country has some form of price control on a lot of things, and it seems like it works out.
No, it's very bad.
I don't know. How bad is it really, Mike?
Did you put the study up?
It's not in the chat. You said it was in the show chat, but I don't see it in the.
Oh,
I don't see it in the show
so
chat.
I invite anybody who thinks that drug price controls don't have a significant effect on innovation to look at virtually any study or meta-analysis on the topic.
Let's read this.
It turns out
the issue. Let's read this. So this is an executive summary of some study, I guess. The issue brief reviews the evidence on the impact of price controls on biopharmaceutical innovation and calibrates what this evidence implies for recent price controls proposals in the U.S. A large academic literature estimates the effect of future drug revenues on R&D spending with a mid-range effect of a 1% reduction in revenue, leading to a 1.5% reduction in R&D activity. Using the range of such effects found in the literature, we find the proposal of price controls of U.S. Bill H.R. 3, the Lower Drug Costs Now Act, would lead to a 29 to 60% reduction in R&D from 2021 to 2039, which translates into 167 to 342 fewer new drug approvals during that period. And it just basically says the same thing. Okay, well, yeah, that's what is this, a meta-analysis that you're linking? You're talking about?
Yeah. And it's not like, people can say, oh, you're just selecting one study. Like, just go look. Like, it's really, it's not like this is one of the contentious areas of literature. It turns out when you significantly reduce the average expected return people can expect on a successful drug, people produce way less drugs. Like, they just invest in creating way fewer drugs. And that's really bad. This insulin has changed my life. My new Omnipod and the new Dexcom, these different medical products have really changed my life. And I absolutely would be willing to pay a lot more for them than, have super price controls, make everything cheaper now and prevent any future advances in my quality of life in the future.
Well, what do you think about those drugs where it seems like, because we're kind of talking all else equal here, right? Like, I would say that I don't think that a lot of the profits that, like, for instance, I think like the EpiPen is got something on my freaking face here that's there or something. I don't know, but I would say that the EpiPen would be like maybe an example of this, where you have this company that's got this IP protection monopoly on this service that like so many millions of people rely on, and there doesn't really clear. There doesn't seem to be clearly the case that like EpiPens just like dramatically get better every single year or anything like that. And it seems like, the capital owners of this company do get like really high, personal capital returns from this company, from this like exorbitant price that they charge for this EpiPen. It's like, okay, well, in that regards, I think that a price control on EpiPens probably just results in cheaper EpiPens. Again, like even based on even basic
think
economic theory would lead you to the conclusion that, in a monopolistic setting, a price control leads to more output, not less, and cheaper prices, right? And so like there's probably some examples where it could make sense, right?
no, like if you did price controls on all pre-existing drugs, you're gonna like make things better for those drugs, right? You're gonna increase output, you're gonna reduce the cost. It's gonna be great because you're taking away a monopoly.
I'm not talking
right?
about that, right? I'm just saying that because I agree.
but-
Again, I've already agreed, right, that fundamentally there's a lot of area where price controls probably don't make sense, but in the areas where
I'm not disagreeing with you very much right now. What I'm saying is, okay, what's the negative impact? Well, if it's a systemic thing that you're saying we're negotiating all drug costs, you've just told all private companies that they can expect their rate of return to go down dramatically. If it's just a one-time thing, well, I guess now there's an expectation that that's now a new norm. I think that ideally we would put a huge package of reforms for encouraging medical innovation, and that could include possibly price controls for any current drugs that have been around for a while, and it could reduce their costs. But it needs to be like you're changing the institutions and fixing this process, because just doing like price controls like what they do in European countries right now, you're just going to reduce medical innovation a lot.
Yeah,
And
of course, I would agree.
another
I mean,
good, it's a good point. People always look at foreign drug prices and they say, well, why do they get away with it? Well, it's like, well, their price controls do reduce global medical innovation. They definitely do. And I think that we should probably incorporate within free trade agreements some sort of drug pricing policy that doesn't allow like smaller countries just to basically say like, oh, hey, rest of the world, like you're going to do your medical innovation and we're just going to like get it for super, super cheap here.
well, I mean, I think I would agree that anybody proposing like a naive price control of just like, why don't we just make drugs free? Or like, why don't we just make all insulin cost $50 a month at the most? Like, that's probably not a good proposal. It's probably a pretty naive proposal, especially when we're not talking about like all those supply constraints and things like that, and like IP reform and whatnot that could make probably a decent difference in outcomes there. And that supply reform doesn't have to be particularly capitalist. Like you could argue that you could have a national drug manufacturing hub or something like this, right, to try and socialize some of the costs of production or something, right? I don't know, but the point is that naive price controls are probably always bad in most circumstances. But I think that if we're having that conversation and saying like, okay, well, all else equal, like what if we had to do a basic, really, shit patch to the current American system, like, are there cases where price controls make sense? We agree the answer is yes to that, right?
It just so like, yeah, for things like where there's no progress that can be made, which I imagine that's a thing, then yeah, that's fine.
Like monopolistic rents in drugs and health, like that's definitely a thing, right? And insofar as monopolistic rents exist, and you're not willing to break up those companies or anything like that, a price control by economic theory like literally just works, right? It's just like probably a good thing.
Well, I mean, that's what intellectual property is all about. It's about granting monopoly rights to give people monopoly rents to encourage them.
No, that's exactly right. That's why I'm saying
yeah,
it's
we just
really
need to fix IP.
Yeah,
IP
exactly.
sucks.
Like there's a lot of other problems that cause the EpiPen to be 1,300% more expensive year on year or something than just the fact that this company is like evil and wants to increase returns, and so that's why we need to nationalize the whole pharmaceutical industry and stuff like that. It's a little bit more complicated than that, and I would agree that the prices that other countries pay for health insurance, I mean, good luck ever getting a country to agree to not do price controls for pharmaceuticals in a trade agreement. That seems like it'd be very difficult to do.
I think you could say for new drugs, like the variation amongst these countries must stay within a certain degree, because you're just not respecting intellectual property rights at a certain point. Because I mean, it is basically saying like the way that we were going to organize our pricing, you will be compensated zero for this innovation that you did.
Well, I mean, at the end of the day, like if a drug company develops a drug in America and then they say they go to the Canadian government and say, hey, we want to market this drug, it's really good for people, and then the Canadian government says, well, we're going to make you charge a price, or like we're going to reimburse you a price that's like economically unsustainable. Well, obviously they would just choose not to market that drug, right? I mean,
so like they're gonna give them a price that's higher than the cost of production, but doesn't compensate them for all of these expenses, these sunk costs that had to go into creating that innovation in the first place. And
right,
that's problematic.
What I'm saying though is that if it was so problematic for those companies, they just wouldn't agree to supply the drug to Canada, right?
I mean,
like
as long as it's above the cost of production, you're gonna market it.
Right. And this is where like some people will make the argument that, well, the reason Canada can do price controls is because Americans pay so much, that like Americans disproportionately make up so much of that sort of premium that other people don't have to pay because we're such a big market and we don't have price controls like that. And my reaction has always been that that's like kind of true, right? Like that is a little bit true. But again, like that's really not, if your main thing is like, I'm going to argue against price controls in America, that's not really a great argument in that regard that conservatives will make. Is like, well, Americans have to pay more because these other countries couldn't have cheap drugs without it. And it's like, well, why do I care about how cheap Canadians pay for drugs? Like, shouldn't I just care about how unaffordable it is for me? America first, right? So
yeah, so it's really interesting because like, okay, there isn't a lot like drug price controls in every country reduce medical innovation, but like there's a sufficient level of medical innovation for people to be satisfied. And maybe the government to be satisfied. And so the American market is so large that just by us like being the sole people to not do it, it's maybe sufficient. I imagine you could make an argument like, why don't we do price controls? So the entire world's like, oh my God, medical innovation is completely stagnated. We need to set up some sort of international agreement to make sure that we're sharing this load because this is not sustainable. I wonder if that would happen. I imagine like, if you're the entire world and you see medical R&D spending go down by like 60%, that would be a little bit concerning.
I mean, yeah, of course, I'm sure. I think that, ultimately, I think we're gonna agree that naive price controls are bad. We're gonna also agree that sometimes price controls could probably be good, but at the end of the day, like those situations where like strict price controls are good are probably like 99% of those cases are probably alleviated by IP reform and like supply side reforms, right? So, there's
a
well, right, but it seemed like originally you were framing like price controls literally never make sense, and it's like, well, no, of course there's examples where they could make sense in our current system, but it's similar to saying like, it's like if somebody said we should just mandate that insurance is only $200 a month. And it's like, well, there's like 1,300 other things you could do to where a mandate like that is probably not even required, right? Same thing with it's like rent control, right? Yeah, I mean, it's like rent control. It's like, well, we could probably make housing more affordable without just strict rent control where we don't need it, which kind of segues us into our other topic. Any last thing you wanted to talk about on healthcare before we move on?
This is so in so many areas, like I think left of center people will have good intuitions, like they're correct on healthcare. I mean, they do a little bit too much greed, worrying stuff, but like, yes, we need more intervention. This is just like, I think broad scale, as you say, naive price controls is an example of real problem, real need for change, bad solution, very bad solution.